Okay. I think I got it all working. Okay. Okay, does anybody have any questions from last night before we start? Okay. Okay, so we left off last night. We started with the respiratory diseases, and the first one we talked about was COPD, chronic obstructive pulmonary disease. We said that it's a condition that takes a very, very long time, decades to develop before a patient starts showing symptoms. But once they have the diagnosis of the disease, there's no going backwards. There's no fix for it. There's just management of it with medications, and that it's not a good quality of life. It affects them for the rest of their lives. It's actually, I think, the third largest killer of people in the United States. I think, heart disease and cancers are number 1 and 2, and that COPD is number 3. So it's, definitely around, not as bad, obviously, as it was years ago, but it's definitely around. And we said that basically in chronic obstructive pulmonary disease, it's one of 2 conditions. It's either a condition called emphysema, okay, in which the damage to the structures in the lung is the alveoli, or it's chronic bronchitis, okay, which the damage is to the bronchioles in the inside of the lungs. Now, in emphysema, what happens is that the structure of the alveoli changes from being a sac that has multiple rooms inside of it into one big sac. And the problem with that is that there's less area inside of it for gas exchange, because there's not those multiple little rooms that the air could go in and have gas exchange, because the capillaries are actually in all the walls of the blood vessels. Okay. The other problem is that the alveoli don't tend to stay open like they normally do, so that with every breath, the person has to kind of force air down into them to kind of reinflate them. And the chronic bronchitis problem is that the lining of the bronchioles is damaged, and the cells that produce mucus go into what they call hyperproduction, which means they produce more than is needed, and that mucus actually clogs up the airway, right? So those are 2 issues that we have. Now, I said that chronic bronchitis is not the bronchitis that we've all had, once a year, once every other year, or something like that, where we get an infection in our lungs. Chronic bronchitis is defined as where they have a productive cough, okay, that lasts a couple of months, 2 or 3 years in a row. So it's just telling you that the mucus producing cells are now changed and damaged, and this is it for the rest of their lives. They're going to have this problem, and it hits them all times of the year. In other words, it's not just something like in the wintertime. And that in either one of these conditions, if they were to get a regular cold on top of it, right? Let's say they just get a regular bronchitis on top of their chronic bronchitis, on top of their emphysema, they would suffer much more than, say, we who just have healthy lungs and then get a cold on top of it. So some of these people can't tolerate the seasonal changes. In other words, when it goes from spring to summer, summer to winter, type of thing, they can't tolerate, say, barbecuing, because the smoke will make them have trouble breathing. So it's very easy for them to, have they call it a decompensation. So compensation means that you're managing it. Decompensation means that you're not managing, you're getting worse. So it's very easy for them to, suffer a breathing attack, having trouble breathing by the littlest thing. And like I said, these people basically every day of their lives spend every hour concentrating on breathing, which is why they tend to be very thin. They tend to be very muscular, because of the fact that they have to use all their muscles. Now, I don't know if your textbook has it, but they typically called the COPD the pink puffer, right? Because their skin tends to be pink, not cyanotic, and I'll explain why in a second. And they called the COPD the blue bloater, like the cyanotic bloater. Bloater means that they're fat with fluid. So the difference between the 2 of those conditions, okay, is that the COPDer, okay, as the body, remember I told you the body never like tries to give up on you. So even though this person for, decades has been abusing their body, the body senses that the level of oxygen is chronically low in these people. So it actually produces more red blood cells. And because there's more red blood cells, there's more ability to carry oxygen. But it's not without a risk. But the more blood cells you have floating in your plasma, the thicker your blood is. And the thicker your blood is, the more likely it is to develop clots. So, it's not without risk. But what happens with COPDers is it's very rare for them to actually get cyanotic because of that extra red blood cells they produce. Okay, in the chronic bronchitis patient, they tend to actually retain some fluid. They tend to do develop cyanosis and stuff like that. Nowadays, they really consider most people having a touch of both conditions when they say it's COPD. So they have both emphysema and bronchitis. I'm sure it's possible to have one and not the other, but most times they have a combination of both of them. We said that the number one cause of it is cigarette smoking, but it could be occupational exposure to, gases and dusts. I know people that work with concrete, mixing the concrete with the dust and stuff like that. If they're not wearing respirators, the silica in the concrete dust is also very toxic to the lungs. The black lung you see over here, we said was years ago when there was coal mining, they would develop what they call black lung syndrome because they would get the dust from the coal into their lungs. They say in certain places, like I think like cities in China, where you see they wear masks all year round, not because of just COVID, but because the air is so polluted in India also, that on autopsy, when they look at these people's lungs, their lungs are actually totally coated with like a black coating on the inside, again, from the years and years and years of, inhaling that polluted air and stuff like that. And, one thing to realize too is there is such a thing as secondhand cigarette smoke. So if you're working in an office around people who smoke and stuff like that, there is such a thing as, secondhand cigarette smoke. My sister had a friend in college whose parents owned bars. That's what they did for a living. They owned multiple bars. And as a kid, obviously after school, since that's where his parents were, he would be in the bar doing homework and then, whatever, just spending, basically all his free time, instead of in the kitchen of his house doing homework, but doing it, in the bar. And at age 20 something, he died of lung cancer. He never smoked a day in his life. He died of lung cancer from the fact that he was breathing in, all that secondhand smoke that was in the bar. So that is definitely, an issue that people have to, realize also. So even if somebody tells you they didn't smoke, but their parents smoked and the parents smoked in front of them, that could be a problem also. So we said that in chronic bronchitis, the tubes, the bronchioles, okay, become inflamed, okay, again, because of the exposure to whether it's the cigarette smoke or the gases or anything like that. And it damages the cells that produce the mucus, and they produce too much mucus. So it basically clogs the airways. And we said that us treating a patient with just regular oxygen out of a tank, not running through a humidifier, can actually make them worse because there is no humidity, there's no moisture in the oxygen in an oxygen tank, so it actually dries out the mucus and causes what's called mucus plugging, right? So this is a picture of a of a normal alveoli. So you have the bronchial, okay, coming down into the alveoli, and you see that even though from the outside it looks like one big, round bag, it's actually made up of multiple rooms. Here they're showing us 5, but there's probably more like 50 because you see there's other little bags around it that they're not showing us the inside of. So the advantage of that is that when the air comes in, inside of these walls are where the capillaries, remember the capillaries are wrapped all around the outside of it, so that there's capillaries all along here, and it's much easier to have gas exchange. Now, in the patient who has, just have to let somebody in. In the patient who has chronic bronchitis, the problem is that because the bronchioles produce so much extra mucus, this mucus starts to clog up not only the bronchioles, but the entrances to the different alveoli. In emphysema, what happens is that it destroys the structure on the inside of it so that this alveoli now it just becomes one big sac. And again, it doesn't tend to stay open. So there's not enough room for gas exchange. Plus, it's hard to get air into it. So both of these are, long-term um, diseases, again, taking many, many, tens of 20, 30 years to develop. But once somebody has it, that's it. They have it forever.
Frank, when I get a call, somebody says that he's not breathing right, he doesn't feel good. I have to diagnose all these problems on scene?
Well, first of all, like I said, in this situation, this patient, whether it be chronic, they're going to say to you they have COPD or they have emphysema. You may even just notice it after a while just by walking into the house and you see the person's very thin. You see they're on home oxygen, right? All these people are going to be on home oxygen. Now, they don't have an oxygen tank. They have what looks like a box about the size of a dehumidifier on the floor that's running. It sounds like a compressor is running inside of it. And it's something called an oxygen accumulator. And what it does is it actually takes the room air, right, which is 21% oxygen, and it filters out all the other parts, all the nitrogen and carbon dioxide, everything else that's in there, and basically raises the percentage of oxygen higher than 21%. Okay. And then pumps it, out of a compressor to usually a nasal cannula or that Venturi mask, that mask I showed you that I said we don't really carry, but that patients who have COPD may use, where they can actually adjust the percentage of oxygen based on the prescription of their pulmonologist, their lung doctor. So, again, this all comes with time and experience. So
what I'm asking, I'm trying to figure out, when I get to a patient, I have no idea what's going on inside. What are the signs to differentiate between emphysema or chronic bronchitis or regular bronchitis? What are going to be my signs that I know for sure to pinpoint what the patient is going through?
I understand what your question is. Okay. So again, like I said, part of it is going to be your history taking, right? So, we have our ample allergies, medications, past medical history. So part of it is going to be your history taking. Like, again, part of it is going to be that it's time and experience. So you're going to start learning medications that people tell you that they're on in their house, what they're used for. So, somebody who is on, somebody who's being treated for bronchitis, or I should say chronic bronchitis, right, would be on different medication than somebody who's being treated for regular bronchitis. Somebody who's treated for regular bronchitis, it's more of an infectious type of thing. So they're probably going to be on antibiotics. Okay. Where somebody who has chronic bronchitis, it's not really a problem with infection anymore. It's a problem that the cells that produce the mucus are damaged, and they're always going to do it. So they're not typically on antibiotics. People on COPDers, they're going to be on medications that help them breathe. So it's kind of a combination of everything, lung sounds. So, we're going to talk, well, we've talked a little bit, but we'll talk a little more about lung sounds. So really what it comes down to is getting out there and actually assessing patients. So you're not going to be out there as a brand new EMT, trying to figure out what's going on with patients. You're going to be, mentored by someone who's been doing this for a longer period of time. And really comes to is like with any profession, any job, is time and experience. The more you do it, the more you see, the more you learn. And that's what it really, comes down to. Okay, so we said that one of the issues in, bronchitis is because of that excess mucus production, that the bronchioles can become clogged up with this mucus, and that if we give them the dry oxygen, the problem will be that it can develop into a plug and, basically close off their airway, right? So that's, one of the issues that these patients face. So we said, again, we want to use humidified oxygen in those patients. We talked about the humidifier really working best inside of the ambulance, not on a portable tank, so that it's okay to start them on non-humidified oxygen in the house and then switch them over to humidified oxygen as soon as possible. And then we said the other COPD disease was emphysema, right? Again, the cause of it is usually cigarette smoking. It can be other things, but usually. And there we said that the inner walls break down. There's less area for gas exchange. The not the lungs, but the alveoli lose their elasticity, which means that they're not staying open, okay, like they should. So they tend to collapse, so that it traps the carbon dioxide down there. It makes it harder for the oxygen to get in. And it just, in general, makes it very hard for that patient to be able to breathe. So now what do we do for them? We said that we want to keep them in whatever position they're comfortable, which is typically the position you find them in. Okay. we are going to continue the level of oxygen they're on in the house. In other words, all these people are on oxygen at home, okay, because they're oxygen dependent. They need more than 21% oxygen, more than room air. So whatever they're on at home, you're going to continue them on, okay? If they're really struggling and, sick, and again, it's hard for you to imagine, like, how do you tell the difference between somebody, they call you to the house and they say, I'm having trouble breathing. How do you tell the difference between somebody who is, mildly sick and very sick? But, all I can tell you is that that comes with time. You're not going to learn that sitting here listening to me reading your textbook. That comes with seeing people and, taking care of people over a period of time. But if they are, in need of ventilatory support, then CPAP is a good way to go. Okay, and then obviously there would be transport to the hospital. The only other thing that may be included in here, depending if the patient has used albuterol in the past, is possibly giving them a treatment, a nebulizer of albuterol. So we'll talk about that when we talk about albuterol. Okay, so now we're going to switch off the COPD, which we, kind of went over last night. So we'll just go into a new one, which is asthma. So asthma is another chronic disease, okay, which means that people typically have it for, the rest of their lives. Now, there's one thing I'll just say is that some of us, myself included, may have had the diagnosis of childhood asthma, right, where we were kids and we were prone to having asthma attacks, and we grew out of it. Okay, so that is possible. Okay, where you get it at young age, okay, and you overcome it, because two things tend to happen. One is that your airways get larger, right? Your bronchioles get larger. And as your bronchioles get larger, it's easier to move air through them. The other thing that happens is asthma is what they call a hypersensitive airway disease. So hyper means a lot, right? Sensitive means that it's sensitive to something, and we'll talk about that. Airway disease. So what basically asthma is that the lungs react to certain things called triggers, like a trigger on a gun. And typical triggers would be stress, exercise, dust, pollen, seasonal changes, when you go from spring to summer, summer to fall type of thing. Every asthmatic has a different set of triggers, that could cause him or her to have an asthma attack. So they call it a chronic disease with episodic exacerbations, right? So this is a little complicated. So chronic means they have it all the time for the most part. Episodic means that most of the time they're okay. They may only be okay because they're taking medications every day to control it. But once in a while, they have episodes where they actually have an asthma attack. Okay, so that's what episodic means. In other words, most of the time they're okay. It could just be they're okay because they're lucky, or it could be they're okay because they're taking medications to manage their condition. Exacerbation is the term for worsening of a condition. So in other words, they have asthma. When they have an asthma attack, they're having an exacerbation of their pre-existing asthma. So it's getting worse. So it's just a fancy way of saying, this asthmatic who was doing okay now has an asthma attack. So what happens again is that their airways respond to some type of stimulus, whether it be dust, whether it be whatever, smoke, change, cold air, warm air. They're nervous about something about their job. They're, kid nervous taking a test. Some people have what they call exercise-induced asthma, that they only have asthma when they're exercising. But something causes it to now trigger their airways to start to tighten. Okay. And obviously, when your bronchioles tighten, we call that bronchospasm, right? Or bronchoconstriction. So it means that the bronchioles start to tighten. Okay. The other thing that happens is they also start to produce more mucus, not to the degree of the chronic bronchitis patient or the cystic fibrosis patient that we're going to see in a second, but they also tend to produce more mucus, which again, why is it's important to give them humidified oxygen. Okay. So the smaller airways, the smaller bronchioles leading down towards the alveoli actually become very tight, almost to the point where people can't move air through them. And if they get to the point where they can't move air through them, those are the asthmatic patients that actually die. So, and asthma does kill, right? There are, asthmatic patients that do die. Now, a person, again, who has asthma knows they have asthma, right? I mean, it's very rare we go to somebody and it's their first time they have the emergency. So most of the times they know they have asthma. There are medications to control their asthma. And the other interesting thing about asthmatics, as far as EMS 911 goes, is that since they've been dealing with their asthma for, probably years, and they have medications in the house, when they start feeling sick, a lot of times they don't call 911 immediately. They start to treat themselves, right? They have medications, they have different things to do. Asthmatics typically have two different types of medications. They have what they call maintenance medications and rescue medications. So maintenance medications are medications that they take on a daily basis, okay, to um, prevent them from having asthma attacks. Rescue medications are medications that they take to break an attack. In other words, that their maintenance medications did not stop them from having the asthma attack. So there's two different types of medications. So every day they may be taking their maintenance medications, but they only would use their rescue medications when they're having it. And 90% of the time, the rescue medication is a drug called albuterol, right? So this is most of the times the same medication we give patients, it's a medication that that the patient would be using also, because it's a quick acting bronchodilator. So the problem of asthma is bronchoconstriction, and albuterol causes bronchodilation. So it opens up the airways so they're able to breathe again. Okay. So now what do we do? Again, they're going to be in the position they're most comfortable in. So we try to maintain that in them. Okay. If they're moving air, okay, we can try to consider giving them some supplemental oxygen, whether it be via CPAP, whether it be a non-rebreather, whether it be a nasal cannula. Again, that's something that you're going to have to gauge basically on the degree of respiratory distress. And, you could also use pulse oximetry, right? If they're telling you they're having trouble breathing, but they're still saturating above 94%, you could probably get away with putting them on a nasal cannula. If they're, below 94%, then you have to make a decision. Would they be a candidate for CPAP, or would you just go with a non-rebreather, right? NRFM means a non-rebreather face mask. Again, albuterol probably is going to be something that we're going to want given them very quickly. They may have even taken it themselves. Somebody just said, what's NRFM? So NRFM, again, is the abbreviation for non-rebreathing face mask, which is, our oxygen mask that we talked about yesterday that we use, that has the bag on it that we have to inflate before we put it on the patient's face. Okay. So nowadays, all the CPAPs that we use in the field have a nebulizer built into them. So you could do both. So if somebody having an asthma attack, actually the albuterol is more important, because albuterol, giving a patient an albuterol treatment with a nebulizer, since we use the oxygen tank as the source of pressure in the nebulizer, you're giving them oxygen at the same time that you're giving them albuterol. Those of you who have kids that need albuterol in the house, you probably have a little box that is basically a compressor that's just taking room air and pumping it through. So you're not actually giving them oxygen. But when we do it, EMS wise, we run the nebulizer off the actual oxygen tank. So we're giving them oxygen at the same time that we're giving them the actual medication. Now, again, if they're not moving air, they're unconscious or anything like that, then just strapping a device to their face and hoping that the patient actually breathes it in is not good enough. So there we have to do what they call positive pressure ventilation, which is use the bag valve mask to force it into them. There's no good way of hooking a nebulizer up to a bag valve mask. So you're not going to actually be able to give them the albuterol in that situation. But it's rare. You're talking less than 1% of the time that you're going to come on somebody who's having an asthma attack. They're going to need to be ventilated. Most of the times you get there and the albuterol is the way to go, and the albuterol is going to open them up. But you may need multiple doses, and we're going to talk about that in a second when we talk about the different drugs and stuff like that.
Are you given albuterol only if the patient is prescribed to it, or you can give it just because you decide that it's?
So I'm going to go over the protocol, but you can give it to anyone who is having trouble breathing and wheezing. Okay. It used to be they had to have a diagnosis of asthma. They had to be between the ages of 1 and 65. There used to be very tight criteria, but about a year or two back, they changed the protocols around. So anybody who's having respiratory distress and wheezing can get albuterol. Okay. So there's not an issue.
So over here again, the EpiPen, if someone is unconscious, would an EpiPen work?
So EpiPen does play a role in an asthmatic patient, but An EpiPen in asthma is very rare to have to get to that point. So that what they require is that if they're at that point, they're unconscious or they're barely breathing, and they're not going to be able to use the albuterol because they can't breathe it in. The only thing different would be that you have to get medical control's permission, right? So there's things, again, we talked about the protocol that are written guidelines of what we're allowed to do, okay? So there are, one part of the protocol are called standing orders, okay? Which means we could do it based on our training. We don't have to call for permission to do it. The other part is called medical control options, which means that you have to call the emergency room and speak to the physician and say, you know, this is what's going on. I'd like to do this. Is it okay? And get permission. So using EpiPen, you know, in an asthmatic would be a medical control option. Using an EpiPen in an anaphylaxis patient is not a medical control option because it's much more common to have to use it in anaphylaxis than it is in asthma. So since it's so rare to have to use it in asthma, there they want you to discuss it with the doctor to just make sure your decision is the correct decision. Okay, somebody wrote a chat that said, what's the puffer they use by asthma? Okay, so all a meter dose inhaler is, again, we're going to do pharmacology soon. I think it's the, we're going to do cardiology next class and then medications after that. But when they talk about a puffer is a device that somebody puts in their mouth and presses a canister that has the medication, and there's a gas in the canister that pushes the medication into the patient. So a puffer could be used for many, many different types of medications, and albuterol can be given by what they call a meter dose inhaler. That's what the medical term for a puffer is, an MDI, meter dose inhaler, which means that it gives a certain amount of medication every time you press down on it. That's what the meter means, meter dose. You give a certain dose each time you press down on it. So some puffers are maintenance medications, which help a patient not have an asthma attack. Even a COPD, same thing, chronic bronchitis patient, they may be taking most respiratory patients take medications that go right into their lungs and go to work versus taking like a pill, okay, that may have to, you know, get absorbed in the body and travel around and stuff like that. So that's what the puffer is. But again, the rescue medication, whether it be by puffer or whether it be by nebulizer, is going to usually be albuterol, okay? And then somebody wrote, is there any difference between a nebulizer and a spacer? So a spacer is something that goes in front of a meter dose inhaler. So let me just, somebody just joined. Let me just see if I can. Hold on one second. I'm going to bring up a picture.
Frank, Ventolin is albuterol, it's the same thing?
Ventolin is another name. When you talk about medications, there's a generic name, okay, and then there is a trade name. So
this is a meter dose inhaler.
Hold on a second.
Also called an MDI.
Hold on. So Ventolin is just the name that a company gave when they first invented albuterol. Okay, hold on. Okay, so you could see the pictures from the internet up on the screen. So a spacer would be from here to here, and this is the meter dose inhaler. So, or here's even a better picture over here on the left. So all a meter dose inhaler is a canister of medication, which is right here, that's inserted in this device. This is a cap that goes over the end of it over here where you put your mouth on it, and you shake it up, you put it in your mouth, you press down, and it releases a certain amount of the medication. The problem is that if you don't time it right, you just spray it in your mouth and you don't actually get it down in your lungs because you have to be doing it while you're inhaling. So they have a device that's called a spacer, okay, which what happens is when you depress it, it's a mist in here and it gives you more time, okay, to be able to breathe it in. So instead of putting your mouth on this, you pop this cap over here and you put it over here. Mainly used on kids because they feel adults can master the timing of it. But I've seen adults use it also. So, you know, it really depends. There's another type of spacer where instead of putting your mouth on it, it actually has a little mask that fits over the mouth and the nose. Okay, so like you see it over here. Okay, so that's all it is. We don't carry meter dose inhalers. We have a regular nebulizer, which is the better way to give the medication because it lasts longer, it goes in deeper, it works quicker and stuff like that. This is something for a patient to carry, okay, with them so that if they have an asthma attack, they can have something very simple that they could administer that doesn't need electricity or oxygen or anything like that. So that's all a meter dose inhaler is. Okay.
If the patient used it already, how do I know how much to give for the patient?
So if the patient treated themselves and they don't feel better, you would just treat them regular. So that's a good question. In other words, sometimes we're going to go on calls where patients have said, I gave myself medications. Okay, so now you have to see, is this the same as a medication that you're going to be giving them also? Because you don't want to give them too much of it. So typically with albuterol is if they've taken their albuterol and they're not feeling any better, we would just go ahead and give them use our nebulizer because we have to assume that the medication didn't get into them. But we're going to talk about other medications that we give patients where if the patient gave it to themselves and we could determine that they gave it themselves properly and the medication's not expired and stuff like that, that we would actually not give it to them. But as far as albuterol goes, if you get there and they say they use their puffer, but they're still not feeling good, which is obviously the reason why they called us, you could go ahead and give them, an albuterol treatment. There would be no problem with doing that. Okay, so let me try to get everything back up and running again. I have no problem removing my virtual background, except I'm not sure that I know how to do that because I'm on a computer I don't usually use, but let me see. I don't even see myself. Oh, I see myself. Okay. Let's see. Video settings. Oh, choose virtual background. Let's see if that's it. Is that better?
It's more natural.
Okay. Okay, so let's get.
You can put it back if you want.
No. It's fine. It's fine. It's not a problem. Okay. I didn't know you could even see me when the PowerPoint is up.
It's look more real.
What's that?
Look more real.
Look more real. Okay, so now let's find this. Okay, is the PowerPoint back up?
No.
No, okay. Let's see what's going on.
I see it on the icon on the bottom of the screen. Just press it, it's gonna pop back up.
What do you see it? It's hiding?
The bottom of the screen, you could just press it and pop it back up.
Because on mine, it's actually taking up the whole screen. So that's why I have to figure out why it's not. Okay.
You don't have on the bottom, you don't see the icons in the bottom? Oh,
No, it's a full.
Okay, now it's on. Now it's on.
it's on.
Okay. 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 Okay, so we said that there's going to be some type of trigger that causes them to have their asthma attack. And when they have their asthma attack, they very quickly feel like they can't get air in, okay? And they're going to, most of the times, try to treat themselves. And they usually tend to only call us when their treatment for themselves has not worked. So we're not getting there usually early into it. We're getting in there later. Now, asthma starts as a problem with exhaling, not inhaling. And the reason why is very simple. I think I even talked about this a little bit the other night, is that, remember, when you're breathing in, inhalation is considered the active phase of breathing, and you're bringing air under force. You're kind of sucking air into your body because it's coming from an area of higher pressure in the room to lower pressure in your chest, right? So it's kind of coming in under force. So even though that patient has those narrowed airways, because the air is coming in under force, it's able to push its way into the lungs. The problem is that exhalation, we said, is the passive or the relaxation, the weaker stage. And now the problem is trying to get air out. So early in an asthma attack, their problem is more one of exhaling than inhaling. So knowing that their problem is more of, exhaling than inhaling, okay, where do you think they're going to have a problem? Are they going to have a problem with getting oxygen in, or are they going to have a problem with getting carbon dioxide out if their problem is more exhaling? What do you think?
Carbon dioxide out.
Yep. So early on in asthma, okay, their problem is more of a problem of getting carbon dioxide out than it is getting oxygen in. Okay. But remember, you have to do both. You have to get oxygen in and carbon dioxide out for your body to work the right way. Okay. But if the attack continues, then they get tight both ways. So what's going to happen is when you get there and you're assessing them and you're listening to their lung sounds, you're going to hear wheezing. The wheezing is going to be starting as an exhalation wheeze, and what they call an expiratory wheeze. So that's why when I was showing you how to listen to lung sounds, right, I said that you want to tell the patient, breathe in, breathe out. So, you know what you're listening to. So if you hear, when you tell them to breathe out, you hear a whistling sound, which is a sound of wheezing, okay, and you suspect this patient's having an asthma attack, okay, because they told you they have asthma and that they're having an asthma attack, right? Because again, that's the typical thing that you're going to hear. If you only hear the wheezing on the way out and not on the way in, you know they're earlier into the asthma attack. If when you listen to their lung sounds, they're wheezing in both directions, that's called biphasic, right? Both directions, both phases of breathing, okay, then you know they're further along. And then, obviously the scariest thing would be if somebody's telling you an asthma attack, they can't breathe, they feel like they're dying. And when you go to listen to their lung sounds, you hear nothing moving. You barely hear any air moving. That means that their bronchioles are so tight that they're barely moving any air. And what's going to happen is they're going to quickly become unconscious and probably go into cardiac arrest. That's rare, but it does happen. People who have asthma do die. When we first started here, actually before I was even Jewish, I remember there was a call on Shabbos. I forgot the name of the street, but it's a little cul-de-sac off of Maple Avenue, where a kid, a younger kid was having trouble breathing, and for some reason the air conditioner did not work in the house. Okay, and he was having such extreme trouble breathing that he actually went into his father's car and started the car up and put the air conditioning on in the car, because he knew that the air conditioning, the reason he was having his asthma attack, because it was the hot, moist air, and that the cool air was going to help him. And they actually found him, dead in the car, because, I guess he didn't get any better, or, he didn't have any medications or stuff like that. So, it is possible for people to die of asthma. We had a nurse that worked in the emergency room that was a bad asthmatic, and she was very stubborn and wouldn't go and get treatment until the last minute. And she also almost died one day from an asthma attack. So it's, is possible. But again, most people manage their asthma now. There's better medications to control their asthma, and they don't typically have, the severe attacks that we saw years ago. Okay, so what do we do? Okay, we said that if they're, whatever position they're comfortable in.
Just curious, what is the response time from the alveolar once you give it? How long does it take to?
So let me ask you. Think about it yourself. So what's going to make the albuterol work quicker or not work quicker?
Well, the inhaling as much
exactly
more that goes in.
Right. So in other words, if they're able to breathe it in deeply and get it down into your alveoli, because in other words, for this medication to work, and we're not really doing medications tonight, but for a medication that works by inhaling, right, you have to inhale it down, not in your bronchioles, but you have to get it down to your alveoli, because what happens when it gets down to the alveoli, it crosses over into the bloodstream, and it's able to start being transported and move and work. So just breathing it, if somebody's breathing weak and shallow, it's not going to work as quickly as if somebody's breathing deep. So when we tell somebody when they're using a albuterol treatment, right, we actually say to them, I know you can't take real deep breaths, but try every third breath or fourth breath or fifth breath, whatever you decide. Try to take as deep a breath as you can and hold it for a second. Okay, so hold it for a second, and then let it out. And what happens is that breath being deeper gets down into the alveoli. They hold it for a second before they exhale it. So the medication has time to get there. And what's going to happen is over a minute, 2 minutes, right, as they start getting more and more of the medication down in there, they start to open up their airways more, and they're actually able to, breathe deeper and get more air in. So I would say typically in an asthmatic, it's probably within 3 minutes. If the albuterol is getting down where it needs to get to, down into the alveoli, they starting to feel better. But there are asthmatics that need back-to-back albuterol treatments. So again, we're not going to talk too much about how we do albuterol, but just realize the typical albuterol treatment probably takes about 3 to 5 minutes to get in. So you're allowed to give 3 treatments, up to 3 treatments in the field. So that's something that, is not uncommon in the treatment of asthma, that the first one may make them feel a little better, but you don't want to just make them feel a little better. You want to make them feel 100% better because you don't want them to go backwards. So it's not uncommon in the treatment of an asthma patient for them to get multiple albuterol treatments, which is why the protocol allows you to give 3. It used to be 2. Now they raised it to 3. So again, Rockland County, to Good Sam or Nyack, you may only finish 1 or 2. And you shouldn't fear giving them 1 or 2, but if you had to, you could actually give them, up to 3 albuterol treatments. Now we'll talk about side effects and things that happen. Like when people take albuterol, they definitely get a little nervous. Their heart rate increases. They get jittery. Some patients don't like the way it makes them feel. But, I always say to them, well, what would you rather, feel like you can't breathe or feel a little nervous and jittery from the medication? So, we'll talk about all that when we actually, cover the medications in depth and stuff like that. Okay, so let's talk about a different one. Okay, so we did COPD now, we did asthma. Now let's talk about what they call acute pulmonary edema / congestive heart failure. So what's the difference? So congestive heart failure is a chronic condition that someone lives in day to day. The most typical causes of congestive heart failure are somebody that has a weak heart. The heart could be weak from having a heart attack. The heart could be weak because the patient has had high blood pressure their whole lives. Okay, the heart could be weak because the valves that direct blood in the right direction are not working the right way. They're starting to fail. So there's many different reasons, but it's a problem with the pumping of the heart, where that not enough blood is pumping out into the aorta, out of the left ventricle into the aorta. So what happens is if blood can't fully get through the heart, the left ventricle would back up into the left atrium. The left atrium would back up into the lungs, right? Because the lungs feed, from the lungs, you go to the left atrium. So now when the pressure in the lungs, now we're talking not pressure of breathing, we're talking pressure in the blood vessels in the lung, the pulmonary capillaries, because the blood can't travel well past them, it starts to pressurize the pulmonary capillaries. So what happens now is that the plasma, the fluid portion of the blood, starts to leak out of the pulmonary capillaries. And the pulmonary capillaries are wrapped around the alveoli. So if the fluid is starting to push out of the capillaries, it flows into the alveoli, and the person feels like they're drowning because now they have fluid in their alveoli where they should really only have air, right? Oxygen in there. So it's kind of what they call a dry land drowning, which means that you're not underwater, but you feel like you're drowning. So congestive heart failure is the person who has it day to day. Okay. And, they probably have swollen ankles. They may have some, the crackles or rail sounds in the lungs, but they manage it day to day. They manage it by watching how much fluid they take in, watching how much salt they take. Because remember, when you have salt, you hold on to fluid. They take medications that help them urinate out extra fluid and stuff like that. And, they have to be careful, but they manage it day to day. They may not be able to sleep flat, but they sleep with some pillows up and stuff like that. But they manage it. When they have the emergency that they call us, it's the correct way of saying it is acute pulmonary edema. In other words, acute means sudden, pulmonary is lungs, edema means fluid in the lungs. Now, sometimes on the test, they'll use CHF and acute pulmonary edema interchangeably. In other words, they won't use one as the chronic condition that somebody has day to day. They'll kind of use them interchangeably. That's why I have them both ways. But in the field, if you go to somebody and you're taking their history, you would say they have a history of congestive heart failure, right? If that's what they tell you, CHF. Or they may say to you, I have CHF. That means that day to day they're managing it, okay? In the field, if somebody said, oh, I just had a really bad, call, it was a acute pulmonary edema call or an APE call, That's because we went in an emergency state where they were having lots of trouble breathing, right? It was a life-threatening emergency. These people get very sick very quick. They're very, very hard to manage because they're so short of breath that they feel like they're drowning. They literally feel like their head is underwater, like they can't get any air in, that they're frantic. They don't cooperate. They don't, work with you to try to help them. So you put oxygen on them, they rip it off. You put CPAP on, they fight you. You try to get them up on the stretcher. They don't want to even lay back a tiny little bit. They don't want their legs up on the stretcher. They want their legs dangling down because it helps the fluid pool away from their heart and therefore away from their lungs. So they're very, very difficult. I mean, this is probably the scariest, toughest medical patient to take care of for a new EMT, because everything you train to do, they don't let you do because they're not thinking clearly, because they're so hypoxic and they're so scared, right? So again, because the heart can't pump out well out the left side, right out into the aorta, it backs up and the pressure builds up in those pulmonary capillaries. That forces the fluid out of the pulmonary capillaries and it flows across into the alveoli. So again, we're talking plasma, right? Because that's the fluid portion of the blood. So now in the alveoli, which should only have air in them, you have fluid interfering with the gas exchange. So that, obviously it's going to be hard to get oxygen in, hard to get carbon dioxide out. The patient gets what they call dyspneic. Dyspnea is the term for not being able to breathe, right? DYS means it's not working right. And PNEA is the term for breathing. So dyspnea, okay, or dyspneic means that somebody's not being able to breathe well. Okay, if there was apnea, so instead of DYS, there was APNE, apnea. Remember, A in front of a word means it's not there. So apnea is not breathing, right? So there's different words, it changes different ways and stuff like that. Did somebody have a question?
Yeah, dyspnea is like difficult in breathing.
Yes. Dyspnea is the medical term for somebody having trouble breathing. And apnea, where it would be APNEA, is the term for not breathing. We at one point we talked about tachypnea. So tachy, TACHY, in front of PNEA is the term for fast breathing, right? So tachy means fast, like tachycardia. So it's just, again, where we're doing medical terminology back in the beginning of class, I kept on saying that we'll repeat words, repeat words, repeat words. This is, again, how we see these words now coming up during the class. Okay, so the common signs and symptoms of somebody having, a problem from acute pulmonary edema or congestive heart failure. Did somebody still have a question?
So apneic is respiratory arrest?
Apneic is somebody not breathing. So yes, respiratory arrest would be a way of saying it. Yep. Apnea or apneic. So you could say somebody's having apnea, means they're not breathing, or somebody is apneic, means they've stopped breathing. So it just depends on, how you're using it. Okay, so again, dyspnea is the medical term for shortness of breath. Anxiety means they're scared because they feel like they can't breathe. Their skin gets, again, cool, pale, and sweaty, just like anybody who's having an emergency, because adrenaline is secreted into the bloodstream. And because adrenaline is secreted in the bloodstream, they get tachycardic and hypertensive, right? Adrenaline, remember we said, is your emergency drug, your emergency hormone of your body. So whenever it goes into your bloodstream, we're always going to see certain things. So we're going to see this pale, sweaty, cool skin called diaphoresis. We're going to have the tachycardia, hypertension. Again, their respirations pick up for two reasons. One, because they can't breathe, right? So they're breathing faster and harder. And also, two, because of the adrenaline secreted into their bloodstream. Their oxygen saturations are typically below 94% because you're not having good absorption of the oxygen coming in because there's that water down in the alveoli. And again, these are very, very acute, sick patients, panic-stricken sick patients, that staying on the scene would be totally inappropriate. There would be nothing wrong with putting this patient on some oxygen, moving them to the ambulance, and en route to the hospital, trying to do what you could do, because you're not going to fix it in the house. Now, we do have one treatment that definitely has improved the BLS care of acute pulmonary edema patients, which is CPAP. Because with CPAP, right, we said that what does it do? It pressurizes the airway. So what it actually does is that fluid that's in the alveoli, it helps to push back out. And even if it doesn't push it back out, since the air that's coming in there is coming under pressure, right, it's helping get it past the fluid. And so there could still be gas exchange. The problem with it is convincing the patient to strap this big device on their face when they feel like they can't breathe, right? So that's the big issue that we face. So it's really kind of being, anybody, if any of you do sales and you're a good salesman, then you'll be very successful with the CPAP on a pulmonary edema patient, because it's really sales. It's, you have to convince them, this patient who's scared and is not really, doesn't want anything other than to feel like they're not dying. You have to convince them to basically strap this huge device over their face, and that it's going to make them better. And it's a very hard sales pitch. And you really only get one attempt at it. If you don't know how to put it on, or you put it on wrong, or you don't do something right, and they all of a sudden feel worse, they're never going to let you put it back on. They're going to fight you from putting it back on and stuff like that. So it's but the treatment in the hospital, okay, the treatment by the paramedics is CPAP. So you could offer the same treatment, okay, that a patient for acute pulmonary edema will get as a BLS EMT. Okay, yes, they will get other medications, an ALS level or in the hospital, but the first treatment that everybody who's in acute pulmonary edema gets is CPAP. And it really does make them better quick if you can convince them to keep it on. So that's the problem. Okay.
All these signs and symptoms.
So again, it's here. So we're right here, right? So again, somebody's going to call you. I'll tell you the typical thing. They're going to call you. It's going to be the middle of the night, and they're going to say they were sleeping and they woke up feeling like they're drowning. They can't even talk to you. Actually, they're so short of breath. So their family's going to say they woke up, they were going crazy, moving around. Look, they're turning blue. They feel like they can't breathe. And what basically happened is that while they were laying flat, okay, this condition came on them. Because they were lying flat, the extra fluid was able to pool over larger areas of their lungs than if they were sitting up, right? If they're sitting up, the fluid tends to travel lower down into the lungs, so that it's not as covering more of their lungs that way. And that they're very short of breath. They're not, they look like they're dying. And when you get there, again, like we said on the previous page, right, you're going to see that their skin is pale and sweaty. They're tachycardic. They're hypertensive. They're huffing and puffing.
I see all the signs and symptoms, but the confusing part is all these signs and symptoms. When someone has an asthma attack, they could also have these signs and symptoms.
Right. So now
how
when
do
you
I
get
know
to,
which one it is?
I understand. So when you get now to their lung sounds, and asthma, we said they're going to be wheezing. Okay. Now, the other thing I keep on saying to you is it's the rare patient, okay, who doesn't have a history of being an asthmatic, doesn't have a history of acute pulmonary edema, doesn't have a history of congestive heart failure. So the first thing is that, when you get there, what we always ask them, has this ever happened to you before? What's your history? Again, you're going to see by their medications that they're on. So, it's kind of what I keep on harping on. But in acute pulmonary edema, and asthma said they're going to be wheezing. In acute pulmonary edema, most of the times they have that rails or crackles sound down into their lungs. Okay, you may even see coming out of their mouth and nose what looks like, you ever see the top of like a beer where it gets that white foamy bubbling? So you're going to actually see what they call frothy sputum. Sputum is like spit, but it's actually the fluid coming out from their lungs. And frothy means it has like the head of a beer on it. And that is the extra fluid being mixed with air. And it gets this, very frothy looking appearance. And sometimes it's actually tinged with a little blood. So it'll actually be a little pink. So some patients get so full, they call it foaming pulmonary edema. So foaming like foam, that it actually comes up out of their lungs, up out of their mouth and nose. So that's rare, but it does happen. So most of the time, somebody in acute pulmonary edema is going to have what they call rails or crackles as their lung sound. Very rarely, there's also going to be some wheezing if their alveoli are so full of fluid that it actually comes up and touches the bronchiole, the tube going down into the alveoli. That bronchiole may start to tighten. And now, because it's tightening, it's bronchospasm, right? Bronchoconstriction, and you get a little bit of a wheeze. But most of the times they don't have that. They just have the rails or crackles. Okay. So, I know everybody wants, like a definitive way of figuring out, like, a lot of these things sound the same, and without actually seeing the patients, it's hard. And unfortunately, your class, like I said, you're going to have a lot of disadvantages because of the fact that you can't ride in the field. Like most classes, students they have to ride 10 hours. Most students rode, 40 to 100 hours out on the paramedic trucks. So by the time they graduated, they already had 30, 40, 50 patient encounters, under their belt, and they saw a lot of different things. we're not letting students ride on the paramedic trucks during COVID. So, it's just a problem, and that the hospitals, I can't even put you in the emergency room because the hospitals are not letting any outside people, students or anything like that. So it's just, unfortunately a problem of COVID. And, it's something that you're going to have to make up on the outside once you get certified. Once you pass your exam and get certified and you start riding somewhere, you're going to have to make sure that in the beginning, you ride a lot with people who are good and know what they're doing and can teach you, can, train you. Now, again, if the vaccines come out and everything's wonderful and, COVID goes away and we still have class, then who knows, we might be able to squeeze some time in. But right now it's only getting worse. I mean, every day there's more and more cases, there's more and more people dying. We're back up to 6, 7, 8 deaths a day now on the 911 side. And, I'd say probably now 50, 60% of our calls are COVID patients. So it's not getting less. And I really don't see it getting less probably until March or April. So it's only going to get worse because of all the holidays and everything that are coming up. So, okay, so what do we do? So these people need oxygen, but they actually need oxygen under pressure. So the best thing in the world for them would be CPAP. Really, no doubt about it. This is where CPAP is 100% home run, totally, the best way to go with it. Again, the problem with CPAP is convincing the patient to keep it on. Even putting them on a non-rebreather and giving them high concentration oxygen may be a problem, because when you're having trouble breathing and somebody puts up something over your face, it makes you feel like you cannot breathe. Now, the difference between a non-rebreather and CPAP is that a non-rebreather is giving you 100% oxygen, just like CPAP is. But a non-rebreather doesn't have a lot of flow. In other words, when you put a non-rebreather on your face, you don't feel like the air is trying to be forced into you, okay? But with CPAP, if you could get them to get the mask on right and sit still and calm, which is hard, right? I mean, it's not like they're doing anything wrong. It's just that they're so scared. But if you could get them to breathe with it for even a minute or two, they're going to find it. Each breath gets easier and easier, because as they open their mouth and breathe in, the CPAP is helping to push the air into them. And what does it do? It pressurizes their bronchioles, it pressurizes their alveoli, and it starts to get that fluid out of the way. Their oxygen level starts to rise, their carbon dioxide level starts to drop, and they start going back to feeling normal. I mean, they're never going to feel 100% normal because they have this big contraption on their face, but you're actually going to, again, if you could keep them on them, you're going to make them look 100% better by the time you get to the hospital than the way they look to you in the house. And like I told you yesterday, sometimes doctors, nurses are going to say, oh, you called up and it sounded so horrible, they don't look too bad. It's because you did the right thing for the patient and treated them the right way. Now, I also mentioned to you that they don't like, to keep their legs up, right? They want their legs dangling over the side of the stretcher, but there's no safe way to transport a patient in that position, right? So it's always a kind of a fight to convince them to sit on the stretcher with their legs up, because they want their legs kind of dangling over the sides of the stretcher. So it's just a battle that you're going to have to convince them to sit back, get the seatbelts on, because there's no safe way to transport a patient sitting upright with their legs dangling over when they're on the stretcher. Okay, so we're going to go over this a little more, so don't feel like I'm rushing through it or anything like that. Okay, so pneumonia is an infection of the lung, right? So bronchitis was an infection of the bronchioles. Okay, pneumonia is an infection of the actual lung itself, the lung tissue, right? The bronchioles are the tubes that go through the lungs. This is an actual infection of the lungs themselves. It can be caused by bacteria, it could be caused by viruses, it could be caused by fungi, many different types of pneumonias, okay? If somebody's on antibiotics, it's a bacterial pneumonia. Viral pneumonias tend to be a little less severe, okay? In viral pneumonias, there's, most of the times the body successfully fights it, or you can try antivirals. This is, again, the problem that we have with, COVID. COVID is a virus, so there's no antibiotic to give a patient, because antibiotics don't work on viruses. They only work on bacteria. They're different forms of disease, right? So, it's a little more challenging when it's viral, but most of the times viral infections are not as severe as bacterial infections, okay? Just so you know, if you could probably talk to your grandparents if they're still alive, and they will remember people dying from cuts. They'll remember people dying from sore throats. They'll remember people dying from pneumonias. routinely, young people, healthy people, because prior to the introduction of antibiotics, when people got bacterial infections, it could be the silliest thing, you know, they cut themselves, you know, and then 2 days later they're dead. When there was no treatment for bacteria, and there was no treatment for bacteria until the Second World War. The penicillin was the first antibiotic, which was invented around the Second World War, so the 1940s. You know, there was no treatment for bacterial infections. So it was not uncommon for people, you know, I mean, to get a tooth pulled, you know, which would have been extremely painful, obviously, could also be lethal because of the fact that there was no antibiotics to be given to the patient afterwards. So there were lots of things, you know, that were considered lethal. I mean, there's a time, you know, where shaving, right? So, you know, somebody shaving their face to remove their hair on their face was considered to be, you know, dangerous, which why it was much more common to have beards, you know, back in the day, because when you shaved, you could nick your skin and cut your skin, and again, introduce bacteria. We all have bacteria on our skin, introduce bacteria into your bloodstream, you know, and then have sepsis and have, you know, blood infection, stuff like that. So it's really only with the advent of, you know, antibiotics that we're able to treat bacteria. The problem now is that the overuse of antibiotics has led to bacteria becoming resistant to the antibiotics. So there are bacteria out there that do not respond to any antibiotics, and those patients die, right? So there's what they call antibiotic resistant, you know, infections. You know, people don't respond. You know, MRSA, for example, right? There's certain strains of MRSA, which is probably a bacteria you've heard about, that, you know, don't respond very easily to antibiotics or need multiple doses of very, very strong antibiotics that could cause other problems, right? Can, you know, damage the body in other ways. So, you know, it's not a 100% cure for it. But what basically happens is either a bacteria, virus, or fungi is introduced into the body, usually by breathing, right? Because it's going into the lungs, okay? And that they start to reproduce and they cause an infection to develop. Now, as that infection develops, the lungs become inflamed so that they don't have, you know, they're swollen, so to speak, and they can't get air in and out. Again, there's always that extra mucus production that happens. Like you see when people have pneumonias, they have that cough because they're trying to get rid of that mucus production. But, you know, long and short is it interferes, once again, with the ability for the lungs to do what the lungs need to do, which is have gas exchange. And depending on how widespread the infection is. Remember, you could have pneumonias that only involve one lobe of the lung. So you have 5 different lobes, right, in your lungs. So you can have infections that, you know, only localize in one lung and one lobe, or you could have infections in all your lobes of both lungs. So it just depends on your overall health and how widespread the actual problem is. Okay. So now, you know, somebody keeps on asking, how are we going to tell the difference? So since pneumonia is infectious, right? And all the other ones, we kind of said the skin gets cool and pale and stuff like that and sweaty. With a pneumonia, what's going to happen? So since they have an infection, one of the ways the body helps to fight infection is to develop a fever. So here, instead of the skin being cool and moist, it's probably going to be warm and moist. And instead of it being pale, it's actually going to be what they call flushed. So have you ever seen somebody outside in hot weather, or somebody who has a fever where their skin almost seems like it's pink or red? So that's flushed skin. And again, this would be something to say to you, okay, so somebody calls you and says, I haven't been feeling good. You know, I got a cough and, you know, I don't know what I have. So now you're going to say, well, is it asthma? Well, asthma doesn't usually have a fever, right? Because it's not infectious. Okay. Well, chronic bronchitis, okay, doesn't usually have a fever because it's a chronic condition. Acute pulmonary edema usually has cold skin, so it doesn't have a fever. So you can start, you know, saying, okay, let me narrow it down to what it kind of sounds like. So they have a productive cough, which means that they're bringing up mucus. They have a fever, and they're short of breath. Okay, so are you going to be 100% certain it's pneumonia? No, it needs a chest x-ray. But that would be a better diagnosis, okay, than say somebody that they might be in, say, asthma, because you're not going to hear wheezing in pneumonia.
Why would someone call EMS for a pneumonia? Usually,
why would somebody call EMS for a toothache? You know, so I mean, you're going to go, if you join Hatzola, you're going to go on calls, and it's going to come in as a severe bleeding, and you're going to get there and the person has a tiny little cut. Okay, so you have to remember that people use EMS, especially in the Jewish world, because they don't actually want to take their kids to the doctor, or they don't want to go to the doctor. You're going to go on remove a tick. You're going to go on, I don't know what, people use the ambulance, especially on the Hatzola side, for the biggest nonsense in the world. I mean, I was having a meeting one time with a bunch of the instructors, and literally a block away from where, we were having the meeting, over the radio comes, I need units for severe laceration, party bleeding. So all these guys jump up to go. I said, no one's going anywhere. Somebody else will go to it. We're in the middle of the meeting. So 5 minutes later, the first unit that was there gets back on the radio and says, okay, it's a minor cut. We're taking the patient to Dr. So-and-so for suturing. So again, for some reason in the Jewish world, the mother will not call up and say, I just have a little cut. I want somebody to come and take a look at it and see if they need to have sutures and stuff like that. They'll make it sound like it's horrible. I don't know why they would wish that on their kids and stuff, but it's just, people call for the strangest things. I've had people call because they had sunburns. I'm not saying just in the Jewish world, but I'm just saying people will call for the strangest things in the world. You'll have people call because they're actually going to the hospital for a procedure, and they don't have a ride to the hospital, so they'll call up and say, I don't know, I have a cough today, I want to go to the hospital. And then when you drop them off in the hospital, turn to the nurse and say, oh, I'm supposed to go upstairs, because today I'm having this done, this test done, or that test done. So people use it for all different reasons.
But on the other hand, I know many cases what was the opposite. They called, well, I need just one unit to come check it out and find out, transfer the patient with ALS to the closest emergency room.
So that is true. You will get people who don't want they don't want the ambulance to pull up. They don't want, their neighbors to come out and look and stuff like that. So they'll just say, oh, I don't think it's anything. Just have somebody come over quietly and, check it out. And then somebody gets there and it's a real emergency. So you're absolutely right. So what it comes down to is you actually cannot trust your dispatch information. So that's what it really comes down to. You have to go on every call assuming, okay, that what they told you may not be right. And you have to go in there with an open mind and say, okay, when I get there, I'll figure out actually what's going on. Not go by the dispatch information that they're telling me, because it may or may not be right. So,
there is a saying, prepare for the worst and hope for the best.
Okay, that's not bad. So like I told you, on Sunday, I had a call where there were 3 patients, all had COVID. So these people were actually nice enough that when they called 911, they basically said, we all have COVID. We are fine. But the wife, she was the newest one with COVID. She can't describe it, but she just doesn't feel well. Okay. She just feels something strange, but she has no shortness of breath, no this, no that. So they dispatch us as a party just not feeling right, but they tell us to call the 911 center. So I call the 911 center. They said, listen, the patient has COVID. The husband has COVID, the daughter has COVID, just be aware before you go in there, which, was very nice, one, of the family to tell you. And 2, nice that we were able to get the information ahead of time. So we're able to properly suit up and protect ourselves and stuff like that. I don't go into houses anymore, without getting suited up anyway. Last probably month and a half, I haven't gone in a house without getting suited up, no matter what it comes in. But, sometimes people are lackadaisical. But, this patient really had no symptoms. I said to him, "Are you having trouble breathing?" "No." "Do you have a headache?" "No." "What do you feel?" "I just don't feel right." And that is a fairly common complaint of people who have COVID, that they just can't describe what it is, that they just don't feel right. I actually had a paramedic today that had COVID 3 or 4 months ago, called me up and said, I couldn't sleep last night. I had the same feelings I had, when I had COVID, and I couldn't sleep. And I said, well, what are you talking about? Like, what kind of feelings? Well, I can't really describe it. I said, well, were you short of breath? No, I just couldn't sleep because I had these feelings. And, he's a good guy. And I'm like, okay, listen, I totally understand. And, take the day off, because, if you didn't sleep, I don't want you to come to work and be exhausted and stuff like that. So, it's definitely an issue. Okay, so somebody wrote, does a patient with frothy sputum, right, that we said that we could see in pulmonary edema, do they need to be suctioned? So actually, sometimes yes. The problem on a BLS level is that you don't really have a good way of deeply suctioning someone because you're limited to basically suctioning to the back of their mouth. So their problem is not in their mouth. Their problem is all the way down into their lungs. So you don't really have a good way of suctioning them. And these people, you know, if the CPAP doesn't help them, they usually wind up being intubated and then they're suctioned through the endotracheal tube. That's a good question. Okay, what sound will pneumonia make? So pneumonia makes the lung sound called rhonchi, which is the sound of extra mucus. It's kind of what you felt or you heard when you had that really bad cough and you were like, you know, and you couldn't get it all out, couldn't get all that mucus out. So it's a very rough sound. Okay. So I'll try to see if I could download some audio clips and play them, you know, maybe next class. I don't know how well they're going to come over the computer speakers and stuff like that, but I'll try to see if I could download some different audio clips of the different lung sounds so we could listen to them.
Maybe you could put it on the WhatsApp group as well.
I have them on the, if you go to Dropbox, actually, I saw somebody today asked on WhatsApp for all the tapes of all the classes. So they're on YouTube, but if you don't, you know, if you have all the filters and stuff and you can't go to YouTube, remember all this stuff is on Dropbox, and on Dropbox, it's also just audio. You don't have to look at the video part of it if you don't want to, if you want to just listen. So it's on Dropbox is everything, and it's everything from every class, and there's just tons of stuff on there. So if you want extra stuff, you have time and you want extra stuff, it's all there on Dropbox. And if you don't have the link, if you lost the link from the beginning of class, then just let me know and I'll send it to you again. And then somebody else
site, Easy Auscultation.
I'm sorry?
There's a site, Easy Auscultation. They have all different type of sounds.
Oh, okay.
It's,
okay, so I'll try
the
maybe.
And everything.
Okay, so we'll go to it on on next week, and we'll listen to some of them. Okay, and somebody else wrote, do people in Sloatsburg have COVID? I would assume so. I don't know what what's funny or not funny, but there's COVID everywhere. There's not a part of the world that doesn't have COVID. They said the only place that there's not COVID in the world is Antarctica. So there's really not a country in the world that doesn't have COVID. So I'm sure there are people in Sloatsburg.
You cover Sloatsburg, no?
What's that?
You cover Sloatsburg. That's why I asked
Tuxedo.
Tuxedo. Oh, okay. My bad then. Okay.
No, there are people in Tuxedo with it. Yes, there's people everywhere. So, Okay, so again, because people are sick with pneumonia and it's more of an infectious problem, they're going to have all the things just like when you got the flu, right? I mean, not that it's the flu, but the same thing. They can have headaches, okay? The skin, again, can be, it's not typically pale, but it's actually what they call flushed, which is reddish. It's going to be warm. They're tired, again, from the, just like when you're sick, okay? The confusion, again, is because of the hypoxia. So, what can we do for these patients? So most of the times we just put them on some supplemental oxygen, transport them to the hospital. But now that they've relaxed the use of albuterol, albuterol is another, like we said, is a good drug, okay, to give to people who are having trouble breathing. So, I wouldn't say it's routinely used in the treatment of pneumonia, but it is a possible, treatment for somebody in pneumonia who's having some, trouble breathing. Again, the oxygen we want to give them should be humidified oxygen because they do have that same problem with a lot of mucus production. So we don't want to dry it out. Okay. And, really what's going to happen is that they're going to determine the type of pneumonia they have. And if it's viral, there's not much they do. It's kind of just supportive care. If it's bacterial, they'll do a culture of the sputum and decide which antibiotic to put them on. Okay. And, if it's fungal, it's really bad. Most people don't get fungal pneumonia. Treating funguses is much harder than treating everything else. Can you put somebody who has pneumonia on CPAP? Yes, but I wouldn't say it's typically something that you would be doing on a BLS level. Again, their problem is more their kind of lungs are kind of junked up with stuff. So CPAP may help, but it's not the most common thing that we put people on for CPAP. I would say it's more the acute pulmonary edema patient would be the number one reason we put people on. The other day, they actually used CPAP on a patient, actually multiple patients who had carbon monoxide poisoning, and they actually seem to have gotten much better quicker than just with a non-rebreather for oxygen. So that was interesting. It was the first time we've used CPAP on a carbon monoxide poisoning patient. Okay. So. Let's see, somebody else has a message. Ready for a break. I am too, but let's give it a couple more minutes. What time is it? 9:15. So we've only been going an hour and 15 minutes. Let's go to at least 9:30. Okay, so spontaneous pneumothorax. So you've talked about with David pneumothoraxes. So pneumothoraxes mean that there is a hole in the lung, or it could be that there's an actual hole on the outside coming in. But it's always what you learned was a cause of pneumothorax is by trauma. Okay. Now, this is something where they have a hole in their lung, but it's not caused by trauma. It's basically that they have weakened areas in their lungs that are prone to rupture. They don't know that until it happens, right? So there's no test that they go for. There's no symptoms that they feel. And what's basically going to happen is that all of a sudden, it may just be at rest. It could be with laughing. It could be with coughing. It could be with taking a deep breath. They feel a sharp stabbing pain, nothing stabbing them. That's the hole that developed in their lungs. And they get very short of breath, okay? Certain people are more prone to it. So very tall, thin people, okay, are prone to it, but I've had short, fat people get it also. Smokers, especially COPDers, are at higher risk for it. Again, not somebody who's been smoking a year, somebody's been smoking, 10, 15 years, but it could happen to anyone. So I don't want you to think that it's just one particular person. But the most common person that gets it is somebody that has Marfan syndrome, which is they tend to be very tall, very thin. And when you look at their fingers, they have exceptionally long, long fingers. It's a disorder of the connective tissue in the body. And for some reason, they get weakened area in their lungs. The second most common are COPDers, okay, that get it. So what they're going to basically describe to you was that all of a sudden, okay, again, it could be with rest, it could be with coughing, it could be laughing and whatever. They got sharp stabbing pain on one side of their chest because it's one lung. It's very rare you get both lungs happening. So it's one lung, and they got more and more short of breath. So everything else now will be exactly the same as the pneumothoraxes that David talked to you about. So when the lung collapses now, if you were to listen to breath sounds on the side with the collapsed lung, those breath sounds are going to be either completely absent or very shallow, very diminished, depending on how much lung collapse they have, right? If they have 100% collapse of that lung, then you're not going to hear any lung sounds. If they have a 50%, then you're going to hear lung sounds, but much quieter. Okay, so they're going to be short of breath. You're going to have absent or diminished breath sounds on their affected side. Now, when David spoke to you, I'm sure he said that there are people who have what they call simple pneumothoraxes and people who have tension pneumothoraxes. The difference is whether or not pressure builds up inside the chest. So let's just very quickly describe what happens. You get a hole in your lung. You take a breath, air escapes out of your lung, but is trapped in your chest, right? If when you exhale, the air goes back out that hole, then no pressure develops. Sometimes people have a pneumothorax where when they breathe in, the air is able to get out of the lung, get into the chest, but when they exhale, it doesn't come back out. What happens is what's called a one-way valve develops, that it lets the air leave the lung, okay, but it doesn't let it go back out. And so every breath they take now, more air escapes out of the lung. And what happens is pressure starts to develop inside one side of the thorax, one side of the chest. And as the pressure starts to increase, it starts to push away, right? So if they have a left-sided, let me see if I can make sure that you can see me actually. If they have a left-sided tension pneumothorax, right, they're going to start pushing now towards the center of their body. So that's what crushes the lung off. Okay, the hole collapses the lung, but this completely crushes the lung off. Okay, and then they will also start putting pressure on everything in the center of their chest. So in the center of your chest, you have your heart, but it's very hard to collapse your heart because you have that pericardial sac around it. But what it could collapse off is the blood vessels coming into the heart. And now the ones that come into the heart are veins, which are low pressure. So it's very easy to collapse on them. So most people get spontaneous pneumothoraxes. They have trouble breathing, but they don't actually get to the point where they have a tension pneumothorax. But it is possible, just like when you had somebody with shot or stabbed. Some people could just have a simple, which means air is going both ways. There's no pressure. Yes, the lung collapses, but there's no pressure developing. And then people are not lucky. They develop that one-way flap, and they get what's called a tension pneumothorax, which is a real life-threatening emergency. Okay. So
is there a way to identify if it's a pneumothorax or a hemothorax?
Is there a way of, if there's a way of identifying a hemothorax?
If it's a pneumothorax or a hemothorax?
So is there a way with your stethoscope? No. But if somebody has, so hemothorax is blood, pneumothorax is air. Thorax is your chest, right? So we should never have air in our chest. We should have air in our lungs. So this is what we're talking about. So the question is, can we tell the difference between a hemothorax and pneumothorax? So first of all, it's going to be trauma. And if you have a hemothorax, you also have a pneumothorax. It's very rare where you just have blood and no air. Okay, so it's going to be usually a combination of what they call a hemopneumothorax. And what's going to happen is that when they're breathing or when they're coughing, or if they have a hole in the outside of their chest, when the air comes out, it's going to be pinkish. So remember, I showed you that video of the guy breathing through the bullet hole in his chest. If you remember, it was like pinkish coming out of it. The same thing, if it was coming out their mouth and nose, it would be blood. Okay, so it would be pink, but it would have air inside of it, so it would be frothy. It would look like the top of the beer head, you know, the top of when you drink a beer, the foam. Okay, but it would be pinkish. Okay.
Why when you have a hole is it called a collapsed lung? Does the lung actually collapse?
Yes. Yes. So the lung does collapse. Okay. Again, it doesn't collapse. The degree of the collapse depends on, you know, how big the hole is and if pressure develops. So you could have somebody who has a pneumothorax and has a 10% pneumothorax. You could have somebody who has 100%. 100% means the lung is completely collapsed. 10% means it's pretty much 90% working. So they're still going to have the chest pain, but they're not going to be a short of breath because they still have 90% of their lung working. Again, it would be very hard to diagnose this without a chest x-ray, right? So yes, you're going to listen with your stethoscope, unless you may hear diminished breath sounds and stuff like that. But, you know, the only true diagnosis is a chest x-ray, to be able to see that on a chest x-ray. So what are we looking at as far as signs and symptoms? So there's going to be a sudden onset of sharp pleuritic chest pain. Pleuritic means lung. Pleura is, you know, lungs, is the lining of the lungs. So what's going to happen is that every time they take a breath, it hurts, right? When they breathe in, it hurts more. So with breathing, they're going to have this, you know, sharp onset of chest pain that increases when they breathe. That the lung sound on the affected side, okay, is going to be either decreased or absent, depending on how much of the lung is collapsed. They're going to be short of breath, okay? Early on, they may be short of breath just with exertion, which means walking or something like that. But as it progresses, depending on how much of the lung collapses, they're going to be, you know, short of breath even when sitting. Their oxygen saturation obviously is going to drop because they're not getting the right amount of air in. They're going to become cyanotic because of that. Again, they're in pain, so their heart rate's going to increase. So, you know, I mean, it's going to be a call where somebody's going to say to you, I don't know what happened. Okay. All of a sudden I felt this sharp stabbing pain in my chest and I feel like I can't catch my breath. And every time I take a breath, it hurts even more. Then you're going to come, when you listen to breath sounds, you're going to hear on the side where they're saying it hurts, you don't see any injury. They're not telling you there was any injury. Okay. They're just saying they were walking or talking or sitting when all of a sudden this happened. But you're going to notice that the lung sound on that side is different, quieter than the lung sound on the other side. And that would be a good diagnosis of spontaneous pneumothorax. Okay. Again, what's going to happen is, you know, when you get them to the hospital, they're going to put what they call a chest tube into that patient, and they're going to relieve the pressure. The hole in the lung actually, once the pressure is relieved, will start to repair itself, and the lung will actually start to reinflate. So just like every wound heals itself, the hole will actually start to heal itself, and the lung will reinflate. Typically takes a day or two, and the lung will start reinflating, you know, and you know, there's not like they do surgery or anything like that. Okay, so that's basically what you do here. Okay, so again, the real treatment is to get them to the hospital because they require typically a chest tube. Oxygen will definitely help them. And this would be one situation where you would not want to put them on CPAP because again, they have a hole in their lung. So if you're putting a device on them that's forcing air into them, you're just going to have more air leak out of that hole, and you're definitely going to take a simple pneumothorax and turn it into a tension pneumothorax. So, you know, this would be one situation. I mean, the other night we went over a bunch of different reasons why you, you know, wouldn't use CPAP. Remember, we said if they feel like they're going to vomit, if the blood pressure is too low, if they're not awake enough to follow your commands. So we had a whole bunch of different questions on when we would or wouldn't use CPAP. But this would be clearly one. You know, anytime there's any problem with the chest or the lung, you don't want to put CPAP on them because it will definitely make them worse. Okay, so let me just see something for a second. Okay, so let's take we are going to go over all the medications. Okay, so we will. So let's take a It's 9:25, 9:35. Come back around 9:40, okay, and we'll pick up where we left off.
Isn't Tuxedo in Orange County?
Yep.
You're Rockland Medics, no?
Yep. So for some reason, Tuxedo, even though it's in Orange County, never really used Orange County for anything. So what happened many years ago was they kept on, before they had their own paramedics, they kept on calling for the Ramapo paramedics to come to them. And the town supervisor at that point was this guy, Herb Reisman, and he was getting very, tired with that because they weren't paying for it. Like in other words, they were using the Ramapo paramedics and not paying for it. So he decided that he was going to cut them off from it. And when he cut them off from it, the town of Tuxedo decided they would get their own paramedics. And since they had used us, previously, they decided to continue to use us. So that's basically how it happened. And they've been there ever since. So, okay, so go stretch your legs. Take a little break. Okay.
Frank,
Yes.
why by the signs and symptoms of a pneumothorax is he gonna have tachycardia?
Well, the most obvious reason would be he's in pain or she's in pain, and also because she can't catch her breath, right? So when you're in pain, when you can't catch your breath, when you're scared, you always secrete adrenaline, and that's always going to cause your heart rate to increase. So that's the most simplest reason why.
Okay, and then if it's already a tension pneumothorax, you're gonna start seeing JVD and the trachea.
Right. But that's again not early. Those are all late signs. So you could see tracheal again. So I don't know what Dova went over and you didn't go over, but Sunday night I will show you different things. So the whole concept of tracheal deviation, in all honesty, is what they call an autopsy finding or an X-ray finding, which means that you don't typically see it by looking at somebody's neck. You really need to see a chest X-ray to be able to do it. So I'll show you some examples, and stuff like that. But yes, on the test, you would answer tracheal deviation away from the affected side, away from the injured lung. So.
Mm-hmm. And then again, I just want to make sure with the blood pressure. Obviously, the blood pressure is going to be dropping because it's putting pressure on the
inferior vena cava and the superior vena cava.
Is that correct?
Yep. Mm-hmm. But only if it's a tension.
Yes, I understand.
Right.
Oh, so again, when it's not a tension, the blood pressure is still going to be okay.
Blood pressure should be fine. Yep.
So it doesn't put pressure right away when it starts. It doesn't
no. It only puts pressure once pressure develops in the chest. So if they never develop a tension pneumothorax, there's not going to be any problem with blood flow. It's just going to be a problem with breathing.
Mm-hmm. Okay.
Okay. Okay, stretch your legs for a couple minutes.
I have a few more questions, but
okay, so let me just stretch my legs. My butt hurts, and I'll come back in and answer your questions.
Okay, thank you.
You're welcome. Pneumonia patients are not that severe, but if they needed oxygen, it would be totally appropriate to give them oxygen. It would be just better to give it to them with a humidifier on it than without a humidifier on it. Okay, so let's talk now onto something called pulmonary embolisms. So pulmonary again means lungs, and embolism is a blockage in a blood vessel. Okay, so this is a little deceiving because it sounds like it's a problem with breathing, but it's actually a problem with blood flow to the lungs. And what happens is that somebody throws a blood clot, usually from their leg, okay, and it gets lodged in one of the branches of the pulmonary artery. So the pulmonary artery comes from the right ventricle, okay, and goes to the lung. And it's bringing the deoxygenated blood that's coming back to the heart, right, coming back to the right side of the heart, and it pumps it to the lungs. Now, what typically happens is somebody develops a condition called DVT, deep vein thrombosis, or somebody has a condition called atrial fibrillation. So a deep vein thrombosis means that because the blood coming from the legs up to the, back up to the heart is really having, it has a hard time traveling up. It's low pressure, you know, it's veins, it's really kind of hard for that blood to get back up, especially in people who are overweight, in pregnant women, or people who stand on their feet all day long. The blood tends to coagulate or kind of clot up down there, right? It doesn't move well. That's why people get varicose veins and stuff like that. So if a clot develops, okay, and then it breaks loose and travels up the veins of the leg, right, up past the diaphragm, eventually it'll make its way back to the inferior vena cava, which is the big vein that comes into the right atrium from the lower part of the body. And when it gets into the right atrium, it'll travel fine through the right atrium. It'll travel fine through the tricuspid valve, the valve between the right atrium and the right ventricle. It'll travel fine through the right ventricle. It'll travel fine through sorry, hold on one second. Whoops. I think I let everybody in. It'll travel fine through the pulmonic valve, the valve between the right atrium to the pulmonary artery, everything like that. So it'll travel through the heart fine. It'll shoot out into the pulmonary artery. And then, you know, the pulmonary artery splits or bifurcates into a right and left one, because one goes to the right lung, one goes to the left lung. And usually it'll go past that split fine, and it'll now get into smaller and smaller arteries that work its way into the lungs. And so in one of those smaller arteries, it'll lodge, it'll get stuck. And now blood cannot get past that point, okay? So what'll happen is, person doesn't know what happens, just all of a sudden, boom, they get this sharp pain in their chest. It's almost similar to the pain that they get when they have the spontaneous pneumothorax. The difference is that when you listen for lung sounds in a spontaneous pneumothorax, since there's now a collapsed lung, one side is going to be diminished or absent. In a pulmonary embolism, there's no problem with the person breathing. The problem is that blood can't get from the right side. So the deoxygenated blood can't get from the right side of the heart, okay, to the lungs to get rid of the carbon dioxide and pick up oxygen. So the person has the complaint of not being able to breathe. They feel like they're short of breath, but it's actually not a problem with moving air. It's a problem with moving blood. Okay, so it's a deceiving by the term pulmonary embolism, because it sounds like it's a breathing problem. The only reason the word pulmonary is there is that the blood clot is in the lungs. Okay, so one reason is a DVT. Okay, and again, people who have surgeries and are in bed, people who have fractures and are not moving as much, they're all at risk for developing these deep vein thrombosis, just like the pregnant woman and the heavy person, the person who stands on their feet all day long. The other condition that puts them at risk is something called atrial fibrillation. So, you know, we talked about this at one point, but remember, ventricular fibrillation means that the lower chambers of the heart that do the most pumping, instead of squeezing, are shaking, and no blood is flowing, the person's dead. And that's where we use the AED. Atrial fibrillation is the same condition, but in the upper chambers of the heart. And since the upper chambers of the heart really don't do much pumping, they're just more or less a holding container. So that when they fibrillate, it's not a big deal as far as cardiac output goes. I mean, it's not great, but it's not a big deal as far as cardiac output goes. But the danger is that if the atriums don't completely empty, okay, so what happens is when your blood is in your atrium and it's going to go to your ventricles, the vast majority of blood goes just because the valve between the atrium and the ventricle opens and the blood just spills down. So about 75% of the blood just comes by opening up. The rest of it happens when the atriums contract. So when somebody's in atrial fibrillation, they still move 65, 70%, 75% of their blood. What they lose is that other, say, 25%, because they don't have the atrial contraction because the atriums are just shaking. So because of that, okay, they now have blood that gets kind of stuck up in their atriums. And because they have blood stuck up in their atriums, that blood can clot. Now, what will happen is that all of a sudden, the patient will come out of atrial fibrillation and the atriums will contract, and then the clot will leave the atrium. And if the clot is in the right atrium, it'll go right atrium, right ventricle to the lung, and they'll get a pulmonary embolism. If it's in the left atrium, it'll go left atrium, left ventricle, aorta. And remember, the aorta comes off the left ventricle and then comes up and arches. And we said off that arch are the three blood vessels that bring blood up to the head, and they'll have a stroke. So atrial fibrillation is a problem in that it can cause people to have pulmonary embolisms or strokes, okay? There is some correlation between women who are on birth control, pills and smoke, they seem to have a higher risk of having blood clots. Okay. And also people who have, you know, problems with fractures where they have splints on and casts and stuff like that. And anybody who has problems with blood clotting, like we talked about before, we said the person who was the emphysemic patient that they called the pink puffer, that's because, again, the extra red blood cells. So they also have a risk of developing clots because they have extra cells in their blood. So it's really, this is a blood clot that develops in the pulmonary artery and doesn't let blood, deoxygenated blood, get to the lungs. And because it's not getting the deoxygenated blood to the lungs, it can't pick up fresh oxygen. So the person has this feeling of that they can't breathe because they're not raising their oxygen level. There's nothing in the world we could do for them but put them on oxygen and drive them to the hospital. It's not a treatment that can be, you know, nothing we could do for them in the field is going to help them. Okay, so somebody said here, how do we tell the difference between a DVT and a heart attack? So it's a good question, right? I mean, they both have chest pain. They both may have trouble breathing. The thing that's kind of different here is the setting of it. So you see here where it's a patient who's bedridden, the patient stands on their feet, it's a woman. A typical heart attack patient, it could happen to anyone. So it's a little, you know, it's a little different. The other thing is that this pain tends to be a very like stabbing kind of pain, just like kind of the spontaneous pneumothorax pain, where somebody who has a heart attack feels more like pressure or like a weight on their chest. So, you know, it is, these are, sometimes it is hard to tell the difference between, you know, all these different types of complaints, you know, when you're assessing patients. But I know I keep on saying it, but the more patients you see, the better you get at diagnosis. I don't know, David, what you wrote here. Somebody, I don't know what you're trying to write. You have to write it a little clearer. Okay, so again, what do you see with a pulmonary embolism? So that same sharp pleuritic chest pain that we had with a spontaneous pneumothorax, okay? You're gonna have shortness of breath, you're gonna have anxiety, you can have some coughing, the skin's gonna get sweaty and pale, okay? But it's the cold sweat, not the hot sweat, okay? You're gonna get the tachycardia, you're gonna get tachypnea, which is the rapid breathing. You can get some mild wheezing, although it's not very common. So these are all not typical things you see in a heart attack, but it's, some of these can be similar to the spontaneous pneumothorax, but what the difference is, again, is that in the spontaneous pneumothorax, you're going to have absent or diminished breath sounds over the side that has the pain. Here, there's not going to be any problems with lung sounds because there's no problem with moving air. The problem is with moving blood. So again, it is difficult to, you know, differentiate this in the field or figure this out in the field. There's not much we could do other than put them on oxygen, okay? And you transport them to the hospital. So there's not any real treatment. They have to give them either medication to dissolve the clot, or they have to try to go in and pull out the clot. So it's not anything that we're going to be doing in the field, okay? Epiglottitis is a infection in your epiglottis. So you know your epiglottis is the flap that when you swallow closes over your airway, so food only goes into your food pipe, into your esophagus, right? So that people get an infection in there and it causes the epiglottis to swell. And if you're closing that flap by swelling, you're going to shut off the opening to the airway. Usually they say it's common in kids, although kids that take vaccines, it's not common in, but you could have, people could have it at any age. And it's really just an infection, a bacterial infection in there. The classic thing is that they have the worst sore throat of their lives and they cannot swallow. So because they can't swallow, they're drooling, their saliva is coming out. So I would say anybody who's had a bad strep throat, just picture it being 100 times worse than the worst sore throat you ever had. That's what basically it you know, it kind of feels like. So again, a very intense sore throat, leaning forward and drooling. It hurts to swallow, just like when you had a really bad sore throat. Okay, they look very sick. They're sitting bolt upright, very concerned, you know, and stuff like that. The muffled voice, again, just like when you had a bad sore throat because you can't, you know, it hurts to talk and stuff like that. They may have that stridorous sound, but they're not breathing that deep, so it's a lot of times hard to hear it. Drooling is when you can't swallow your saliva, so it comes out of your mouth. You know, so your basically your spit is coming out of your mouth because it's too painful to swallow. Okay, so there's really nothing to do with these patients to get them to the hospital. You don't want to, on a test, there's always a question about looking in their mouth. You don't want to do anything that could cause anything to make that swelling get worse. So we don't do anything to make them upset. You know, if they'll tolerate oxygen, we could put them on oxygen. But if it's going to make them worse, you know, we don't want to do it. It's really just getting them to the hospital as quick as possible. What they actually do in the hospital is they bring them right to the operating room, and they try to pass a breathing tube past that swollen epiglottis into their trachea. And so they knock them out. They try to pass this tube. If the tube can't pass, they have a surgeon to make a surgical opening, a tracheostomy into their trachea. So they'll cut open their trachea and pass the breathing tube that way into them. Once they get their airway secured, then they get on antibiotics, right? So I mean, they'll be put on antibiotics the same time they're having surgery. But in other words, once their airway is secured and the antibiotics are flowing in, the antibiotics would deal with the infection, and then the swelling will go down. So, but it's really an acute airway emergency, just not that common. Okay. Croup you may have had with your kids. So croup is a viral infection, typically affects kids between 6 months and 5 years of age. Doesn't mean that you can't have it younger or older, but most common between 6 months, most common in the winter. At night, typically the kid has a history of, you know, being a little sick for a couple of days, or there's siblings, brothers and sisters that are a little sick for a couple of days. And what'll happen is that all of a sudden they'll have this barking cough where it's like a, you know, like a very loud barking type of cough that, you know, they'll wake up with a lot of times, and the parents will hear it. They'll rush in. The parents are very scared. The kids are usually scared, but it is usually not life-threatening. Okay. It is, again, it's viral. There's not really, you know, a whole lot to do for it. Really moist, humidified air is the best thing for them to breathe in. And, you know, we usually take them to the hospital and stuff like that. So it's this barking seal-like cough that they typically hear. Very rarely do they have that stridorous inspiratory sound, that sound. Most of it's like a type of barking cough and stuff like that. So humidified oxygen is the way to go, transport them and stuff like that. You may have heard the different like home remedies, which is that sometimes you bring them out in the cool night air and it helps them. Some people say putting them like in a steamy bathroom with the shower going on hot helps them. The cool night air, so cool air does reduce swelling. So it probably does help them a little bit, but you don't want, you know, they need to be dressed warm. You don't want them shivering. You don't want them crying and stuff like that. So cool night air does help a little bit. So if you get there before the ambulance and people, you know, the family have them out there, that's fine. It's just a little hard to assess people in the dark. So usually we do bring them back in the house. As far as the shower goes, believe it or not, for this particular situation, it would be actually better if the water was on cold, and you wouldn't put the kid in the shower, but if they could sit right outside of the shower and just breathe in the cool, moist air, that will also help reduce, because cool reduces swelling. Warm makes swelling. So this is a swelling problem, you know, where the airway is kind of getting tight up top. So cool, moist air would actually help them better than warm, moist air. Warm, moist air works better when somebody has like a lot of mucus in their nose and stuff like that. But for this one, it would actually be cool, moist air would work better. Again, it's not that we have to stay in the house and do that. We would just put them on humidified oxygen and transport. So somebody asked, why do we look in the mouth? So it's kind of silly. You're not going to see anything is the real reason. But what they're concerned about is that you're going to try to stick something down there to be able to see better, and that you're just going to aggravate the area that's swollen and make it swell more. That's what they're really concerned about. So that they always have that in a test, you know, when would you not want to look in the throat? In all honesty, we never look in the throat because there's nothing really to see. We don't have the right instruments to look into somebody's throat or anything like that. So, okay, cystic fibrosis they're not going to have on a test, but just so, you know, in case you ever come upon a patient who knows it, it's a problem. It's a genetic problem, you know, typically develops early in childhood and stuff like that, where they just, because of, again, a gene problem, they develop a lot of thick, sticky mucus that actually can close off their lungs and cause them problems as far as their stomach goes. Okay. And, you know, so they tend to be very thin. They don't have good nutrition, and they have a lot of breathing problems. They need to be suctioned constantly. They need to be on medication to thin their mucus so that it can clear up. And they're very, very prone to developing these mucus plugs, especially when they're sick. There's nothing we could really do for them. Put them on oxygen, make sure it's humidified, and take them to the hospital and stuff like that. So there's not really much we could do for them. And it's really going to be, they're not calling you because of the cystic fibrosis. They're calling you because they get a cold, they get a pneumonia, they get a bronchitis, and they know that when they have this problem, okay, that they're going to get sick pretty quickly. So they want to get to the hospital so that they're, already in the hospital to be able to be treated and stuff like that. Okay, so again, humidified oxygen really is the way to go. Most of the times, the parents, because again, this is kids, the parents are a very good a source of information on how best to manage their child. So, I mean, there are sometimes parents aren't, but most of the times, one, if not both of the parents know what to do for the kid. And if they seem like they're competent and stuff, you could be guided by what they tell you, and they can help you with the suctioning and stuff like that. Okay. Viral infection. So we've all had a viral infection in our chest. It's called a chest cold, right? Actually, coronavirus is a viral infection. There's just different types of coronavirus. This one is called COVID-19, but there's different types of coronaviruses. It's basically the kind of common cold type of thing and stuff like that. Just to realize that when people have underlying breathing problems like COPD, asthma, whatever, and they catch a regular cold, they're going to get much sicker than somebody who doesn't have these underlying medical conditions. Because what happens now, not only are they battling the cold, right, or the infection, but it's going to make their underlying breathing problems worse. So, a lot of times these patients do winding up in the hospital just with a, runny nose, because it makes their other condition worse and stuff like that. Okay, so just like pretty much everybody else, some humidified oxygen transport. Okay, so now let's go over some of the different treatments and stuff like that. So the metered dose inhaler, the prescribed inhaler, right? It's called the metered dose inhaler again, because when you squeeze it down, it gives an exact amount of medication out, okay? So there's some metered dose inhalers, okay, that are used to prevent people from having breathing problems. So these people take them every morning, sometimes twice a day, to prevent them from having breathing problems. Those are called maintenance inhalers. And then there are some that are called rescue inhalers that the patient only takes when they actually have an emergency. Okay. Most of the times the rescue inhalers are medications like albuterol to help them. So we are allowed to assist a patient in taking this if they don't know how to use it. I've never met a patient who doesn't know how to use it, but they may not 100% know how to use it right. Okay. So for this to work right, the medication is not supposed to be swallowed. It's supposed to be inhaled. Right. So it's not supposed to be swallowed into their stomach. It's supposed to be inhaled into their lungs. So they have to time it so that when they depress the top down and spray the medication into their mouth, they're actually inhaling. So what they're supposed to do is shake it up for, a couple seconds. Okay. Exhale as much as they can. And as they're inhaling, they put it in their mouth and press it down and take a deep breath and inhale the medication into their lungs. How you know it got down into their lungs is they will cough. Okay. Now, some people are told to take 1 puff. Some people are told to take 2 puffs, whatever it is. And that's what they do. So, if they don't know how to use it, you just, instruct them how to use it. Again, younger patients may have that spacer device between it, which just gives them more time to inhale the medications and stuff like that. Okay. Whenever we talk about medications, so on the test, they're going to say, what do you have to know is correct before you give a medication to a patient? So it has to be the right patient, which again, EMS wise is not usually a problem because we only usually have 1 patient at a time. The right time, which again, EMS is not an issue because, the time that we give them the medication is the time we get there because it's an emergency. So a lot of this stuff is from the hospital standpoint, right? They walk in a room, there's 2 patients, so they have to make sure they have the right patient. The doctor said a specific time to give the medication, but that doesn't really pertain to us. So again, the right drug, so we have to know which drugs to use in which situations, the right amount of the drug to use, and the right route to administer it. Okay, in other words, does it go as an injection? Does it swallow? Does it go breathe in and stuff like that? We always want to check the expiration date. We said that we're going to shake up the inhaler for a couple seconds. Okay, we have to make sure the patient is awake and alert enough to be able to use it. And if there is a spacer device, we can have the patient be able to use it. So again, here, they're just making sure everything's right as far as using it with the patient. This is an inhaler, a metered dose inhaler. So this is the metered dose inhaler right here. This is the spacer, okay? And it just plugs in right into the back. If you didn't have this, then you can't see it, but the little part that's sticking out over here is the part that would go, in your mouth. So all the chamber does is just gives you more time. There are some chambers that if the person is breathing too rapidly and not breathing slowly like they should to get all the medication in, it'll make a whistling sound to kind of let them know that they're breathing too rapidly and stuff like that. So again, we want the patient to exhale deeply, okay, and then to put the device in their mouth and depress the inhaler while they're breathing in, okay? And they should take a deep breath, hold it for a second, and then exhale, okay? And we'll know that it worked because they'll cough. Now, as far as the nebulizer goes, so the nebulizer is another way of giving medication by inhalation, right? This is the route that we're treating these patients is inhalation because they're inhaling into the lungs. It just works better because it's moist. It's in smaller amounts, okay? It's not a one-shot type of thing that they have the time to get down there. So it's just a better way to give the medication. Again, it's not something that somebody could carry with them. So that's why there's always going to be meter dose inhalers. So that if a patient's out in public, they could have a device they can carry with them to help them until other people get there. Okay, so we are allowed to use inhalers on patients. The drug that we put in the nebulizer to give them is called albuterol. Okay. And, when they talk about small volume nebulizers, talking about there's not a lot of fluid in it. There's different ones and stuff like that. So what happens is that the medication is in a liquid form. And as you run the oxygen through the nebulizer, it turns it into a mist that the patient then inhales. And the mist obviously has the medication in and stuff like that. Okay. Typically takes a few minutes for the patient to get it in. Okay. And it just allows that medication to get down into the alveoli and be absorbed and stuff like that. So the drug that we use is called albuterol sulfate. You can also see it called Preventol and Ventolin. Those are manufacturers' names for albuterol sulfate. That's all it is. Like, Tylenol, you can buy the name brand, or you could go to Costco and buy the generic brand, right? So the name brand is Tylenol, and then acetaminophen is the, generic name. So it's just a marketing thing, Preventol or Ventolin, stuff like that. So what albuterol is a rapidly acting bronchodilator that's useful in anytime somebody has bronchospasm. The most common disease that causes the bronchioles to constrict, okay, is asthma. But there's other things, anaphylaxis, there's other things that cause the bronchioles to constrict, and asthma would be the most common reason why you would give albuterol. Okay, so we are allowed to use albuterol on any patient, okay, who is having trouble breathing and is wheezing. Okay, now the way the protocol is written is that if you have training in using albuterol, which you will have, then you're allowed to use albuterol as your first line. If you don't have training in using albuterol through a nebulizer, then you would help the patient use their meter dose inhaler. Okay. But again, you're going to be allowed to use the nebulizer, so that would be the better way to treat the patient. Hold on one second. Okay, so now the drug we said is a bronchodilator. It does have some side effects. Okay, so it is going to make the patient's heart race a little bit. Okay, so let's go through them. So nervousness means that they get a little shaky. Okay, I've not seen patients get dizzy from it. I guess it's a possibility, but really the most common things is they get a little nervous. Okay, they get a little shaky. That's the tremors. Their heart rate increases. Palpitations is when somebody feels that their heart is beating faster, right? Tachycardia is that we feel the pulse, but palpitations is the patient tells you they feel their heart racing. Okay, skin getting maybe a little flush might be common. Not so common for somebody to have chest discomfort, but the most common things is that they say they feel like a little nervous, a little jittery, and they feel like their heart's racing and stuff like that. Okay, so again, we could give it to anybody who's wheezing and in respiratory distress. The most common reason why is asthma. Both the agency that you're working for, okay, writing for, and the EMT must have approval to use it, which, by taking the EMT class, you're cleared. Okay, the albuterol comes in a preloaded little plastic tube that has 2.5 milligrams of the albuterol and 3 milliliters of normal saline. NaCl is the abbreviation for normal saline, which is just kind of like 0.09% salt in water. So it's kind of like the equivalent amount of salt that you have in plasma in water. So it's just like if you had to give somebody an IV and you wanted to be as close as the fluid in their body, that's what normal saline is. Okay. And we adjust the nebulizer at a rate between 4 to 6 liters per minute. Most of the times it's 6 liters per minute. Okay. But you can go 4 to 6 liters per minute. You don't have to wait on the scene to finish the nebulizer because the nebulizer takes a few minutes to get in. And you're allowed to give a total of 3 doses. So once you finish the first dose, if they're not feeling 100% better, you give them the second dose. And if the second dose is finished or not feeling 100% better, you give them the third dose. Okay. Again, in Rockland County, you probably won't have time for the third dose, but you are allowed to give up to 3 doses. Okay, so why do we use it? The indication is to relieve bronchospasm because it's a bronchodilator. So most of the times it'll be asthma, but it does have some other uses. When we get to the other emergencies, we'll talk about them. Okay, in patients who have histories of heart problems, we used to have to call medical control before we gave it, but now they just basically say use caution. In other words, the respiratory problem is pressing. It needs to be treated. So we still give it, but just to realize that if they've had a history of heart problems, they may have more of those side effects that we talked about before and stuff like that. When would you not give it? So hypersensitivity means they have an allergic reaction to the medication. I've never met anybody who has an allergic reaction to albuterol. I've had people tell me that they're allergic to the preservatives in medications and they're concerned about taking medications because they're allergic to preservatives, but I've never heard of somebody saying they're actually allergic to albuterol. But if somebody says to you that they are allergic to it, then obviously you can't give it. Okay. Now, I wrote here as a contraindication, patients in respiratory failure. So remember, respiratory distress means somebody is having trouble breathing. Respiratory failure means that that trouble breathing is so severe now that it's affecting their level of consciousness, that they're not breathing deeply anymore, they're not staying awake. So those patients that when they move to that respiratory failure, they're not going to be awake enough to use a nebulizer. So you're just holding in front of their face when they're not breathing deep means the medication's not going to get in. So in that case, when they're in respiratory failure, it's kind of too late for albuterol. They just need to use the bag valve mask and ventilate them. But if you get somebody early who's having a lot of trouble breathing, you may be able to either use the nebulizer, or if you feel if they're not breathing well on their own, maybe use CPAP with the nebulizer to be able to kind of force that albuterol into them. Okay. So, and I'm assuming they're going to be having a session coming up. I'm going to check with David tomorrow about your next skill session when they're going to be going over using all the different medications and the equipment to use those medications and stuff like that. So again, the dosage, not that they usually ask you any dosages on the exam or anything like that, maybe just the epi dosages when we get to that, but it basically comes preloaded, right, in a little plastic vial. It has 2.5 milligrams of the drug floating in 3 mLs of normal saline. We run the nebulizer 4 to 6 liters per minute, and we could give up to 3 doses on standing order, okay? So it doesn't usually take 10 minutes to get it in, but I would say probably 5 minutes, 3 to 5 minutes to get the first one in. If that doesn't work, you can give a second one. If that doesn't work, you can give a third one. So a maximum of 3 doses. So now to put it together, you have to assemble the nebulizer, add the medication to it, attach your oxygen to it, run the oxygen at 4 to 6 liters per minute, hand it to the patient, okay, and tell them how to use it. So again, it's more important that they breathe deeply than they breathe fast. It is hard for them to breathe deeply. So you could tell them if you can't breathe deep on every breath, give me every other breath or every third breath, and give me a nice deep breath, hold it for a second, okay, and then exhale. And what's going to happen after a couple of minutes, you're going to see that they start coughing. And it's a very distinctive cough. It's not like a cough when you're sick, but it's like a like they can't get enough air in to give a big cough. That's actually telling you that the albuterol is getting down to their bronchioles and starting to open things up. And that's a good sign. You'd like to actually see that. And then what's going to happen after a few more minutes of using the albuterol, that's going to go away. They're not doing it constantly. They're doing it on and off. That's going to go away and they're going to start breathing normally. Now, for very young kids, we may not actually be able to have them master using the nebulizer, in which case we would just have it blowing in front of their face and have them inhale the mist that way. Although my experience with very young kids who use albuterol on a regular basis is that they're very skilled in using it and they could actually put it together themselves and give it to themselves. They don't even really need you to help them. So, most of the times patients like young asthmatics, since they use it so often, they know how to do it together. So what do you do to put it together? So when you open up the bag, it has various different pieces. So this piece screws onto here and makes what I call the acorn like the little nut that falls out of an oak tree. Okay. So this is the chamber that the medication is going to go in. Some people pour the medication in it right now and then screw this on. I usually put it together and then pour the medication down here because less of it spills out. So after you put that on, the next thing probably would be to put the T piece on. So the T piece is that this piece goes right here and it looks like a T. Okay. So you see that's this piece here is going over here. And then on one end of the T piece, the mouthpiece goes on. And the other end, some of them have a piece of plastic tubing that comes off. Some of them don't. I'll show you that in a second. And then at the bottom, you could barely make it out over here, but this little clear projection you see from the bottom here is where the oxygen tubing fits on. Okay. Now, if you ever have oxygen tubing where one end is blue and one end is green, the green always goes to the oxygen tank and the blue always goes to the device. And if there is going to be a blue, usually this thing is colored blue also, or there's some kind of blue marking on it, just to show you how it hooks up. I don't know why it is. Sometimes it's just clear and they fit either way. It doesn't matter. And sometimes they're color coded where the green only fits on the oxygen tank and the blue only fits on the device. This is how most people carry the albuterol. So again, there's 2.5 milligrams of albuterol and 3 mLs of normal saline. And what basically happens is when you twist this piece right here, okay, it breaks the neck over here, and then you could squirt the medication down in here. I'll just tell you from experience that if you put one finger here and one finger here, like you're holding it like this, and put pressure on it while you're breaking this off, a lot of it will squirt out. So instead of putting one finger here and one finger on the back, put one finger on the side and one finger on the side and hold it sideways. There's a spine along here, so it doesn't squeeze the way it squeezes from here. And then when you open it up, a tiny little drop will still spill out, but you won't lose as much as if you have pressure here and on the back of it. So just hold it. And I have plenty of expired ones that I'll give to David so everybody could practice, opening up. This is the nebulizer with the corrugated tubing on the other end that I told you some have and don't have. Just this helps to trap more of the medication so that when they inhale, they're inhaling medication back in, not just room air. So some have them, some don't have them. It doesn't matter. And again, it's all hooked up to the oxygen. The patient's holding it. Sometimes they hold the tubing to hold it. Sometimes some of them like to hold the actual medication chamber to hold it. It doesn't really matter, how they hold it. This is a nebulizer mask for people that cannot hold it, and you could strap it on their face. So what happens is you have the nebulizer, but you don't plug it up into the T-piece here. So you would just take, this piece right here without it going up into the T-piece, and then you plug it right in here. And then you strap it on the patient's face, and it goes in that way. Okay. Most of the BLS ambulances don't usually carry this, just the paramedics carry it. It's very rarely used. You could actually take a non-rebreather and grab the bag and yank it out and make the same thing. And then just pull the little gaskets off that are on the side of the non-rebreather and make the same thing. Okay, so let's do a quick review and then we'll see if anybody has any questions. Okay, so, obviously percentage of calls that we go on, I would say respiratory emergencies probably, 10 to 20% of the calls that we go on. And we reviewed all the anatomy and physiology of how the respiratory system works the first night. Okay, and tonight we talked more about the medications. People that start breathing very shallow and slow, okay, it's a bad sign. Unless they're in fantastic shape and you're meeting them for dinner and a conversation, you happen to notice, that they're in great shape and they're breathing slow and shallow because they're in such good cardiovascular shape. It's usually a bad sign, because when somebody breathes very slow and very shallow, they're not moving enough air in, so their tidal volume is not adequate and their respiratory rate is not adequate, so they're not moving enough oxygen and carbon dioxide around. Now, once somebody starts to get in that condition where their breathing is very slow and ineffective, because the heart becomes hypoxic, the heart slows down because it doesn't have enough fuel, it doesn't have enough energy. So you see somebody breathing very slow, very, very shallow, and their heart rate is very slow, is bradycardic. That's telling you that at this point, the only thing you could do for them is use the bag valve mask and breathe for them and try to increase them. Again, this is not going to be somebody who's awake and conversing with you, right? If they're awake and conversing with you, it's probably a normal condition. It's probably that they are in just great shape. They run every day, they exercise every day, and they called you to the house for a completely different reason other than breathing, right? They, whatever, twisted their ankle or something like that. So, there's no, this is not going to be a situation if it's an emergency that somebody's going to be awake and talking to you and stuff like that. Okay, we talked about all the different things that we look at when we're examining a patient. We talk about pulse oximetry and stuff like that, lung sounds and so on. And we'll go over this, time and time again. Okay, we talked about albuterol and the medication. We're going to review again all the drugs okay, that we're going to use. We'll review CPAP again, when we use CPAP and when we don't use CPAP and stuff like that. We'll talk about the indications to use it versus the contraindications to use it and stuff like that, one more time. Okay, so now let's go some questions. Okay, so what would you expect a patient's respiratory rate to do when a patient gets hypoxic? So hypoxic means that the level of oxygen is low. So what would you expect their respiratory rate to do initially when they start getting their oxygen level drops? Okay, so what do you expect? It's going to do what? It's going to actually increase to try to do what? To compensate, okay, and get more oxygen in. So initially, when somebody starts to have trouble breathing, they tend to breathe deeper and faster to try to get more oxygen in. If that doesn't work, in other words, if the reason why they're having trouble breathing gets worse, then what's going to happen is they'll start going the other way. And that's when they move from early, what they call respiratory distress, into later respiratory failure. And then untreated respiratory failure goes to respiratory arrest, which means that they are not breathing anymore, or the medical term, apnea. Okay. So again, what would you expect the pulse rate to do? So just like the breathing increases, you need the heart rate to increase to circulate that oxygen, right? Because if they were breathing in more oxygen, but the heart is not pumping faster and harder to circulate the oxygen, that oxygen would be useless. So again, initially you would expect, so the earliest vital sign changes you see in somebody who's starting to have trouble breathing is everything speeds up. It's when everything starts to slow down and somebody's having trouble breathing that we're very, very concerned. Now, what's the signs of inadequate breathing? We said that they, one, just are visual looking at them that it looks like they're having trouble breathing. They shouldn't be able to speak in complete sentences and converse with you if they're having severe trouble breathing. Okay. They may be in that tripoding position where we see them trying to support themselves with their arms so that they get a little more air in. We said that they may be breathing with pursed lips. They may have nasal flaring. You may see them using accessory muscles to breathe. You may see that the muscles between their ribs are pulling in. That's called retractions. So, this is, again, unfortunately, something that you have to see and experience to be able to see it. I'll actually try tomorrow, if I have a few minutes, to go on YouTube. Sometimes there's good videos taken in the emergency room where they black out the patient's face of people having various different breathing problems. So there may be some ways to see stuff, without actually, being in front of a patient. Okay. Okay, it says, what would you expect to assist a patient with their inspired inhaler when they're experiencing congestive heart failure? Why or not? So most of the times, people in congestive heart failure don't use an inhaler. A inhaler having albuterol is more for people who are having problems with bronchospasm. So in a congestive heart failure patient, this is kind of like a trick question. In a congestive heart failure patient, it's a problem with fluid, too much fluid in the body. And an inhaler is not going to get rid of that fluid. So most of the times, you would not be using an inhaler on a patient in congestive heart failure. Differences between the adult and pediatric respiratory systems. So, again, we said really all the passageways are smaller, right? So that's one issue. So it's easier for them to become obstructed, whether or not there's a foreign body, or obstructed because they're having constriction, bronchoconstriction, laryngeal constriction, or whatever. They're having a problem where their airways are trying to tighten. We said that the tongue in a child tends to take up more space in the mouth of a child than the tongue of an adult does. And that when they become unconscious, it tends to more easily obstruct their airway. So it's something to always think about. That the back of their skull tends to be very rounded. So if we lay them flat, they tend to flex their head forward and close off their airway. So sometimes we'll have to put some towels under their shoulders to build it up. And here we have a 72-year-old female who complains of severe shortness of breath. Husband notes that she is confused. You note a respiratory rate of 8 breaths per minute in cyanosis, has a history of COPD and CHF. So what would you do? So right off the bat, would you say she's stable or unstable? Right? So she's breathing 8 times a minute, she's cyanotic, and she's confused. Okay? So she's clearly unstable. Nobody at 72 years of age should be breathing 8 times a minute. Okay? Nobody should have cyanosis, right? Unless they're having a breathing problem, unless they were in cold water or something like that. Plus, she has a significant history of chronic obstructive pulmonary disease and congestive heart failure. So this is a train wreck of a patient, right, who, we have to manage. Without seeing her, we can't say 100%, but she is going to need oxygen. She may be a candidate for CPAP, but again, if she's confused, probably she's not going to be able to work with you to use the CPAP. So this is probably somebody who's going to need to have the bag valve mask and be ventilated with the bag valve mask. She's breathing too slow, right? And she's obviously not bringing enough oxygen in. So probably this patient is going to need the bag valve mask. Again, without seeing the actual patient, it's a little hard to say, but she's probably going to need to be ventilated with the bag valve mask. Okay, so does anybody have any questions or anything they want to go over tonight?
I do, but not necessarily from tonight's
Okay.
lecture.
Okay, so I sent out a not a WhatsApp, a Zoom invitation for Motzei Shabbos. So any questions you have about anything, Motzei Shabbos, I'm going to start out with going over anything anybody has on the trauma, because some people have texted various different questions about, seems like the head trauma section was the part that had most of the questions. But any questions you have about stuff, I'll go over. If you want to start, texting me questions, to prepare for Saturday night, I could do that. And then we can go over anything else you have, on Motzei Shabbos. And then I don't know which nights we're meeting next week, but I'll take a look and see, which nights, and I'll send out the invitations for that. Okay.
For group, you say we're using a cold shower.
What did you say?
Group, you make cold water, not hot, and child is pooping.
Yeah. So I'll just tell you that most people think steam is best for them, but really what happens is that if you were to take a washcloth with hot water, right, and put it on your skin, you'll see that your blood vessels dilate and relax, right? So croup is a problem with swelling in the airway. So warm, moist air will just cause more swelling. Where warm, moist air helps is when there's a lot of mucus, but croup is not a problem with mucus. So what best helps somebody who has croup is cool, moist air. That's why sometimes taking them out in the outside, the cool night air sometimes helps to reduce the swelling.
Right. That's what I do. I take my kid to the shower, to the room, and I take hot water. Then I go to the freezer or outside for 1 minute.
Okay. Yeah. So, I mean, I'll tell you, it's definitely the most common thing is people put them in the shower with warm, moist air. But if, you could try it. You try again, you're not putting them in the shower.
No, in the room.
Yeah. I would just have them stand or sit right outside the shower and have the cold water running and have them breathe in the cool, moist air. It's basically the same thing as taking them outside without taking them out into the cold air because it's uncomfortable. And if you have a kid who's sick and you're taking them out in the cold, freezing night, it's a little more uncomfortable. So it'll, again, most kids who have croup are also prescribed steroid medications to help reduce the swelling too. It's just that the steroid medications, when you're taken orally, typically take like an hour to start working. So if you have a kid who has a history of being croupy and you start seeing that they start looking like they're getting a little sick, it might actually be better to start giving them a medication before they actually start getting the breathing problems to prevent them from getting the breathing problems.
For COVID, is a cold air or a hot shower?
COVID will not really, so it's so hard to say because this time around, there's not as many people having the respiratory part of COVID. So, and again, if they are having it, it depends on what their complaint is, right? I mean, it's kind of hard to say. Most of the patients I've seen with COVID who've had respiratory problems are so sick, you're not going to actually be able to have them, stand or sit next to, a shower. I mean, they're just flat out, in bed. So, I don't think this is something for COVID. This is, I wouldn't worry about this kind of stuff for COVID. It's not anything that's going to happen. Somebody sent a text asking to go over OPQRST. So OPQRST is a way of remembering the questions to take when you're trying to tunnel into a complaint, right? So somebody says to you, I'm having trouble breathing. So the O is onset, okay? So onset is, when did it happen? Okay. What were you doing when it happened? Okay. Provocation again is, does anything make it better or worse? Okay. The Q is quality. Can you describe it to me? Okay. The The R is, does it radiate? So that doesn't really pertain. That's more like pain. You know, in other words, if somebody's having chest pain, does the pain go anywhere else? Okay. S is severity on a scale of 1 to 10, with 10 being the worst. Okay. Can you tell me how bad it is? And then anytime we do any treatment, we ask them if it changed the number. So in other words, you know, let's say it's the patient who had that spontaneous pneumothorax and they're complaining of chest pain. So we'll say on a scale of 1 to 10, 10 being the worst, how bad is the pain? Probably they're going to say 10 or 12 or 15, because that's a real bad pain. And then we put them on oxygen and we say to them, okay, has it changed the pain at all? Again, in that situation, it probably wouldn't. The one time I think that you're going to do a PQRST and pain is going to change is if you're having somebody who has chest pain and you're putting them on oxygen, say, okay, then you may see the pain go down a little bit. You know, so they may say the pain was an 8 out of 10. And because you calmed them down a little bit, put them on some oxygen, it's now a 7 out of 10 or something like that. And then the T is for time, again, just to know how long it's going on. But you could probably, like we said last night, we could probably figure that out because we know the onset of when it started. So O is onset, P is provocation, Q is quality, R is radiation, S is severity, T is time. Okay, that's all in your book.
Frank, the CHF is not the same thing as cardiac, as the shock and
Cardiogenic shock?
Cardiogenic shock, yes.
No.
It's the same symptoms. No, it's the pipe between both the ventricles.
So cardiogenic shock is, I would say, death, somebody dying from CHF. Cardiogenic shock is, that's a good question. Cardiogenic shock is that somebody's heart is so damaged that they really pump no fluid out. So yes, they go into acute pulmonary edema, but they actually go into shock from it. So it's basically somebody's heart is dead, is dying, is you know, I mean, yes, it's still kind of working, but it's so damaged they can't pump anything out. So you're not wrong to say it's kind of like it, but it's, I would say it's the worst possible pre-death part of acute pulmonary edema is cardiogenic shock. So very rare, very, very rare. Okay.
So when are they calling it APE? When they're calling it CHF? I never heard not solo. They always say APE. They never say CHF.
So CHF would be somebody who has a problem with their heart. Okay. In other words, they've had a heart attack in the past. They've had
history,
a valve problem, you know, something like that. And day to day, they have to watch their fluid intake. They have to watch their salt. They, you know, their ankles are usually swollen. They have to sleep with some pillows, but they get by. They're not having an emergency where they're running to the hospital. They manage themselves. When they then have severe trouble breathing, we typically call it acute pulmonary edema. The reason I put it both ways is that on the state exam, it's used interchangeably. You can see in one question, they'll say, patient states a history of CHF, they can't breathe, you know, they're scared, they're nervous, what should you do for them? And then another one, they'll say, you know, patients in pulmonary edema, you know, they're scared, what are you going to do for them? So they use it kind of interchangeably because the way the state exam is, it's a test bank of thousands of questions. And they'll say, make a question of 110, a test of 110 questions, and it'll randomly select, you know, 10 respiratory, 10 cardiac, 10 this, 10 that. So you never know what kind of questions are going to appear. So just so you know both ways, you're right. In real life, I would say somebody's going to tell you they have a history of congestive heart failure. And then when we get called to their house because it's an emergency, we would call it acute pulmonary edema because it means they suddenly, all of a sudden, their lungs filled up with fluid. So it's like a worsening of congestive heart failure. You could have it very rarely where a person has no history of congestive heart failure and something went terribly wrong with their heart suddenly, and they flash over into pulmonary edema all of a sudden. But most of the times they have some cardiac history. Okay. Somebody wrote, why on a pulmonary edema, I guess, well, see, PE can be pulmonary edema or it can be pulmonary embolism. So I'm not sure which one you're asking. People die in minutes. Oh, embolism. You still have the other lung working. Okay, so good question. So what you're assuming is that the embolism went to one of the lung. But remember I said that off the right ventricle, right, the pulmonary artery comes off the right ventricle and then it splits. Where it splits, right, is called the saddle. If it hits that saddle and it's a big embolism, but if it splits that embolism, if it hits that split and lodges right there, it shuts all blood flow from going from the right side of the heart anywhere, and the person dies almost instantaneously. It's called a saddle embolism. So if you see somebody sitting on a horse, their legs are on either side of the horse. That's kind of how the artery splits, right? It comes like splits that way. If it hits right where the split happens, it basically shuts any blood flow going from the right side to the left side. So obviously the person instantaneously dies, which is actually this time around, there's a lot of pulmonary embolism cases with COVID. So, and there's a lot, I hear much more in the Jewish world than any place else. A lot of people dying of pulmonary embolisms. So that is not uncommon with COVID. COVID does cause what they call hypercoagulation. So hyper means a lot. So a lot of coagulation, a lot of clotting of the blood. So there's people having heart attacks, there's people having strokes, there's people having pulmonary embolisms, all again from the hypercoagulation problem with COVID. So that's definitely an issue. But again, it could happen if it passes the bifurcation, the split, and lodges right away in one lung, because you're basically shutting off 50% of the blood that's going to travel to the left side of the heart. So it could happen even with just one lung. It really depends on how large the clot is. The bigger the clot, the more likely it is for somebody to die. The smaller the clot, less likely for them to die. It's just a matter of luck, to be honest with you. Any other questions? Okay. So everybody have a good night, good rest of the week. Have a good Shabbos. Okay. Try to rest up and, be careful. Take good care of yourselves. And I'll see everybody, God willing, after Shabbos. Okay.
Thank you. Thank you so much.
You're welcome. Have a good night, everyone.